the judges and the participants, I'll invite Sanjay Dutt sir to take over.
Thank you, Ashok. Good evening, everyone. Good evening, Dr. Shah. Good evening, Dr. Sachin Kale, Dr. Ashish Padnis, our secretary. Dr. Shah, as you know, is a famous trauma surgeon who has been professor of Nihar Hospital, and today he has consented to be here with us. He's one of the pioneering surgeons in trauma surgery. Uh, we have also with us Dr. Sachin Kale, who is professor of D.Y. Patil Medical College. Again, a very avid writer and orthopedic writer and trauma surgeon. We have with us, as you all know, Dr. Ashish Fadnis, who is the secretary of Bombay Orthopedic Society. And today he is the judge also. Besides, I don't think there's any other judge, Ashok.
Ashish is there.
Ashish, Sachin, and Dr. Shah. And I also would be a judge, unfortunately. So welcome the these participants. It's a proud privilege to host you there. You have done excellent in the last round, and it is our good luck to see you here in the second round. And I'm sure you'll do well. All of you are good, excellent winners. And unfortunately, we can only send, I think, 3 winners to the finals. So today it will be a real brass tacks. And so I welcome you all. Dr. Yash Ved from, I think, KEM Hospital. Dr. Nihar Modi also is from KEM. Dr. Mitali Mokashi I don't know where she's from. I'm not read her CV, but she's also from KEM. So it is a KEM Storm. Then Abhishek Nighot. He's also from KEM.
He's on Sancheti right now.
He's Sancheti. And Dr. Soham Ranade. He's from?
MGM.
MGM.
Soham, I think PG is from South India somewhere.
Oh, yeah. And Dr. Taarini Johri. Yeah. Yeah, Soham. You want to say something? Soham, you want to say something? Anyway, Dr. Taarini Johri, who is not right now with us, as she's flying in somewhere in Europe. She's joining AO course in Davos, but she'll be speaking from there. So she is from right now doing a spine fellowship in Hinduja and also from D.Y. Patil Medical College. So welcome again for the second round and the real tough round where 3 of you would be going to the finals. Dr. Ashok would read you the terms and conditions and the guidelines, which you already know, but we'll again repeat it for you. And I wish you all the best for this round and see you, 3 of you at least, in VIROC finals. And anyway, I thank you for participating and taking this contest to a next level. And I'm sure we'll see you more in future in orthopedic academics. Back to Ashok.
Thank you very much, sir. And I'll just read the guidelines in short. So all the presentations here are on review of literature on the given topic. So students will be presenting on latest literature, at least last 5 years to 10 years. And they will summarize the literature review that they have done. It is not a case-based sharing kind of lecture, but only on review of literature. So that is one of the most important points. The marking will be done on their presentation skills, the content that they have accumulated and how they have organized the content to make it more logical, more rational, and how they have put forth their thought process. So that is the most important point. Then structure and organization of their slides and question and answer in terms of how they answer the questions and interact with the judges. So there will be 8-minute presentation for each candidate, and there will be around 3 to 4 minutes question and answer from all the judges included. And the marking will be done on these bases, as well as there will be some bonus points if somebody does extraordinarily well in question and answer session or in presentation themselves. So like sir said, we'll be selecting 3 out of 7 contestants today, and they will be presenting in VIROC on 22nd December. We'll let you know what the exact timings are, but it is 22nd December. So we again welcome you all. I'll also like to thank all the participants of round 1 of Rising Star. They all did extremely well and participated, and hopefully they will be able to participate again next year if they are not made up to round 2. So with that, let's begin with our
Just one
first.
clarification, Ashok. I
Yes, sir.
think Neeraj is pointing it out that probably five of you might be able to go to the finals. So
Okay.
that I think we'll convey to you later.
We'll
Three
convey to you.
definitely, maybe five.
Yes. So with that, let's begin with our first contestant, Dr. Aditya Chaubey. You can start your presentation. You can share your screen. So Aditya will be speaking on influence of spinopelvic alignment on total hip arthroplasty. Aditya, go ahead. I'll be keeping the time and I'll be mentioning how much time each contestant is taking.
Good evening, everyone. Sir, is my presentation visible?
Yeah, your presentation is visible. You can go ahead.
Okay. I'm Dr. Aditya Chaubey, and today I'll be speaking on the influence of spinopelvic alignment on the decision making in total hip arthroplasty. To introduce my topic, I would like to show this editorial called The Death of the Leeuwenhoek Safe Zone, written by Lawrence Dorr in the Journal of Arthroplasty. This stems from studies like this, where large registry data has shown that 58% of the dislocated total hips had a cup that was within the Leeuwenhoek safe zone. So one wonders whether it can be really termed as safe. There must be some sort of a missing link that can explain this discrepancy. And probably it is the understanding of spinopelvic biomechanics. We know that the hip and spine are a part of the same biomechanical chain, and they have to move in coordination across different postural changes. So the acetabular version does not remain static, and it keeps moving with changes in the movement of the pelvis. So a cup that may have been implanted in a satisfactory position may not remain in the safe zone across the entire breadth of the physiological movement that takes place. As shown in this systematic review, the spinal alignment changes most between the standing and sitting positions, where on sitting down there is a decrease in the lumbar lordosis, decrease of the sacral slope, and increase of pelvic tilt, and resultant increase in the acetabular anteversion to accommodate the femur that is flexing forwards on sitting down. To prepare this presentation, I went through electronic databases with a filter to include studies in the last 10 years using appropriate keywords and Boolean operators to identify relevant studies to this talk. We know and studies show that patients with abnormal spinopelvic alignment, such as patients with ankylosing spondylitis, are at an increased risk of complications, including dislocations following total hip arthroplasty. The same is true for instrumented spinal fusions, where large registry data of more than 200,000 patients have shown almost a 2.5 times higher risk of dislocation when total hip arthroplasty is done after spinal fusion surgeries. And more the number of levels of spine that have been instrumented, the higher is the rate of dislocation. This is true both for early as well as late hip dislocations following total hips. Now that we understand the problem, we have to identify the patients at risk of this problem, as shown by these two landmark studies that were published in the Bone and Joint Journal regarding the utility of a lateral radiograph of the LS spine up till the proximal third of the femur, where we can identify the stiff spine based on changes in the sacral slope between the sitting and standing position. The normal range of change of the sacral slope is between 10 to 30 degrees. Whenever this is less than 10 degrees, the spine is said to be stiff. Also, we have to see if the spine is balanced or not. A balanced spine is one where the difference between the pelvic incidence and the lumbar lordosis is less than 10 degrees. Whenever it is more, there is a flat back deformity. And based on these two categories, the patients can be divided into different groups and treatment recommendations made accordingly. For example, in this case, we can see a instrumented lumbar spine which is posteriorly rotated. So it is a so-called stuck sitting position. In this position, whenever the patient will stand up, there will be risk of posterior impingement and tendency to dislocate anteriorly, as a result of which in these cases, the acetabular anteversion has to be kept slightly less in order to accommodate the femoral extension. Conversely, in this case, we can see a lumbar spine which is fixed in increased forward flexion of the pelvis. So this will tend to impinge anteriorly when the patient sits down and as a result dislocate posteriorly. So while doing total hip for such a patient, the anteversion has to be kept higher to accommodate the femur that is flexing forwards. Coming to the concept of the combined sagittal index that was introduced by Heckman et al. In 2018, it is the sum of the pelvifemoral angle and the anti-inclination of the acetabular cup. They showed that a higher combined sagittal index in the standing position was a predictor for posterior impingement, and a lower sitting combined sagittal index was a predictor of anterior impingement when the patient sits down from a standing position. And this serves as an invaluable tool to plan the process of total hip, where they have shown that a standing combined sagittal index between 205 to 245 degrees reduce the risk of dislocations. Integrating this concept into the pre-op planning workflow has been shown to reduce the risk of dislocation following total hip replacement. Now we come to the controversial decision of whether to address the hip or the spine first in these patients. As shown by large registry data, we see that the patients with prior lumbar spinal fusion undergoing total hip arthroplasty had almost a 106% higher risk of dislocation as compared to those who underwent spinal fusion after total hip arthroplasty. However, this decision is not so simple. There are also studies that show that in case of severe spinal deformities with a kyphotic spine, spinal osteotomy procedures that correct the spinopelvic parameters may help to lower the risk of dislocations in THA that was performed subsequently. So the current consensus that exists is that if a hip flexion contracture is present, in that case, the total hip arthroplasty must be done first because in itself that may improve the spinal biomechanics. Otherwise, the more symptomatic problem has to be addressed first. For example, one might need to do a spinal instrumentation earlier if there is a risk of neurological deterioration or if there is a significant spinal deformity that is present. Dual mobility cups have been gaining a lot of popularity recently, and they are an invaluable tool if used correctly to address these sort of spinopelvic imbalances. Large registry data has shown that use of dual mobility articulation in high-risk patients has been associated with lower risk of dislocation at both 90-day and 1-year follow-ups. Also, computer navigation has now been proven by number of meta-analysis to improve the precision of acetabular cup placement. And in the future, it may serve as an important tool to identify patient-specific safe zones and then predict the position of the acetabular cup based on various preoperative imaging. And in this cohort of 1500 patients, it showed really promising results. As you can see in the scatter diagram on the right side, a lot of the acetabular cup positions that were in the functional safe zone ended up being outside the traditionally defined Leuvenec safe zones. That highlights the importance of understanding the spinopelvic alignment. The future directions that research in this topic might take is the clinical validation of our understanding of spinopelvic biomechanics with more prospective studies, and also the implementation of our understanding of functional safe zones to train robotic systems to achieve a optimal spatial acetabular cup orientation. Some of the take-home messages that I'd like to leave you with is now we need to move beyond the Leuvenec safe zones and understand the importance of the sagittal balance in dictating the stability following total hip arthroplasty. We must use dynamic imaging in preoperative planning to identify the high-risk patient cohorts and need to individualize treatment strategies based on that, including the judicious use of dual mobility articulations. These are my references. Thank you.
Thank you, Aditya. I'll invite the judges for their questions. Dilip sir, you can go ahead first.
Yeah, first and foremost, I wanted to request you that we couldn't see you, Aditya. You should have kept your video on. Is it a rule that we should not see them?
No,
Sir, my
no.
video. Sir, my video was on.
I beg to differ. Okay, many of them may not agree with you. Now, I'm trying to ask you that you have seen that New Horizons will show that the whole idea of the system which you said is not so good. So, are you going to delineate any new guidelines from your side? You have given three very important points. But then, if there is a patient with ankylosing spondylitis and you want to do osteotomy, will you do osteotomy first or will you do the hip first?
Sir, it depends on the degree of spinal deformity that the patient has. So, if there is a stiff spine that is also kyphotic, so there are different treatment options that are possible. It is also possible to do a dual mobility total hip arthroplasty if that is possible and achieve a good range of motion without impingement. However, if dual mobility is not a possibility in that patient, then correcting the spinal alignment to give a more functional position of the acetabular cup and then doing the total hip arthroplasty may also be a viable option. So both options are available depending on how bad the spinal deformity is in that patient.
You have shown the possibility of dislocations correlated to spine, but in general, we normally use inclination of 45 degrees and antiversion of around 12 to 15 degrees. In order, we do not use this guidelines. What would be the position of acetabular cup in inclination and antiversion point of view?
Sir, it depends on the uh, how flexible or rigid the spine is and how the pelvis is balanced. So that is the whole point, that this standard inclination of 30 to 45 degrees and standard antiversion is not really valid. You have to individualize it based on what the patient has. So suppose if it is in a stuck sitting position, then 15 degrees of antiversion may still lead to a impingement and dislocation. So you have to reduce the antiversion. And the same is true for different other situations. For example, if it is in a stuck standing position and you keep the antiversion slightly low, maybe 10 degrees or 15 degrees, then again it is going to dislocate. So you have to keep it slightly higher, maybe closer to 25 degrees.
Okay, and next, Josh, you can start with your questions.
Yes, sir. There, sir, you can ask.
Yeah. Excellent presentation, Aditya. Very well, concisely presented. From your, I couldn't see anything regarding imaging modalities. So after this literature review and your own experience, what would be the imaging modalities which you would recommend to a surgeon like me, who is not very knowledgeable about spinopelvic alignment? So
Sir,
what are
the
the
most
imaging you would recommend?
Sir, the single most important imaging is a lateral X-ray of the LS spine, where we can see up till the proximal third of the femur, so that we can assess the changes in the sacral slope, because this entirely it is a dynamic concept. So we have to see dynamic imaging. One static view is not going to give so much information.
So
So a
what about the
lateral,
dynamic? What would be a dynamic study?
sir, this LS spine lateral view, which is done in a sitting and a standing position. Also, some studies have shown that apart from these two positions, they do it in the supine position and one step up position where one limb is on a step and one is on a step below. And for navigation systems, usually CT scan is required, but for the basic understanding of the spinopelvic parameter of a given patient, the LS spine X-ray lateral view is the most important imaging.
So in navigation, would you, I don't know, I have not experience of navigation in hips at least. So would a CT-based navigation be more useful in this, or a dynamic CT, like dynamic navigation like what we have on table to see the assessment, mobility, everything? I just want, this is for my curiosity. From
Sir,
the
as
literature,
far
could you study?
as far as I am aware,
So
the
like in knee,
navigation,
would many people prefer
yes,
a
sir.
CT based? They say that there's always Ashish might say that his system is much better than my system. I use a dynamic. So in case of hips, have you learned anything from the literature that?
Sir, in the literature, they have not really mentioned. Whatever little literature that I could find where the navigation has been used to implement this sort of a spinopelvic alignment, they had used the CT-based system, but I don't know if it will make much of a difference because intraoperatively it is going to give the dynamic situation, whether it is CT-based or imageless.
Okay. So one last question. Does post-operative protocol in these would be different in spinopelvic wherever you find a stuck sitting spine or stuck standing spine? Would a post-op protocol change, or it would be still once you have
Sir,
decided the angle, you have decided the inversion, would you sort of mobilize faster or in some positions like we conventionally give abduction bars? Would that really matter? Is there any difference in post-op? I'm talking of literature. I know you may not have your own personal opinion.
Sir, in literature, they have not really described their post-operative protocols very well, but then these all precautions depend on a lot of factors, like what approach has been taken. And definitely, if there is a patient who is at higher risk of dislocation, even if intraoperatively we have taken all the precautions, I don't think it will hurt to be a little bit slower in rehabilitation and prevent any sort of dislocation from happening because none of this is foolproof. It is just that we have to not just worry about it post-operatively, but intra-op also we have to try to address the issue.
Okay, that's all. You can move ahead with Ashish.
Yeah, Ashish, you can go ahead.
Yeah, did a good presentation. So I wanted to ask you a couple of things. One is there an influence on age on spinopelvic mobility? And have you come across any references which allude to the fact that the same pelvis in a younger age group can behave differently than when the patient is older?
Yes, sir. Literature does talk about that, and typically with increasing age, we see that there is spinal decompensation. There may be degenerative disc disease and facet arthropathy issues. So generally, with increasing age, the pelvis tends to rotate posteriorly, and also the flexibility of the spine reduces. So the change in sacral slope that we measure, that becomes lesser.
So, and is there any association of acetabular dysplasia? You know, sometimes you have shallow acetabulum, sometimes you have acetabulum which are retroverted. So, is there an association of acetabular dysplasia with disturbed spinal pelvic biomechanics?
Yes, sir, that is also related. So typically in case of hip dysplasia, the flexibility will not be affected. So the change in sacral slope is normal, but as you said, the pelvis tends to be rotated forwards to provide that additional anterior coverage. So in that position, when we are doing THR for such patients, we need to tend to keep the anteversion higher so that we do not allow the anterior impingement and posterior dislocation in hip dysplasia patients.
And I wanted to go back to a presentation actually, but just remind me in your presentation, have you included a paper from India?
Sir, I have not included any paper from India. There are two papers, one from Kerala and one from All India Institute of Medical Sciences in New Delhi. But both of them are review articles which have basically spoken the same thing. So I included the original articles that spoke about the
Okay.
spinopelvic parameters.
Okay. I think that's it. I mean, from my side.
Sachin, sir.
No, nothing. Nice presentation. Roughly, most of the questions are asked. Any limitations you feel of this? Because any special investigation you want to do for the sacral slope or role of flexion extension X-ray?
Sir, regarding flexion extension X-ray, basically in sitting and standing position, some amount of flexion extension at the spine is also being assessed. Main limitation is that there are no prospective studies. All of these are retrospective level 3 evidence based on joint registry data. So to implement all this knowledge prospectively and see how the results come is perhaps one of the limitation that exists today.
Okay.
Just one last question. Did you read anything about obesity? I mean, in those we always get lost. in obese patients. So there,
No,
does
sir.
it really?
With regard to this, I didn't read, although in obese patients, again, the flexible and unbalanced phenotype that is there, that is more common in obese patients. But
Okay,
specifically, I didn't read of outcomes in obese patients.
okay, thank you.
Okay, thank you, Aditya. I think that was a
At the
nice
end of this
presentation.
presentation,
Yeah.
you said that these guidelines may become obsolete, and you have shown three new ideas. So, what new three ideas are going to be implemented by you, and you are going to present a paper on that, or you will continue doing with the same guidelines?
No, sir, definitely I will try to use the new ideas now that we know it.
Okay, wonderful.
Thank you.
Okay.
Thank you, sir.
Thank you, Aditya. Let's move on to the second candidate. Meanwhile, we'll give some time for the judges to give marks to Aditya. So while I invite Dr. Soham Ranade, judges can give their marks. Soham, you can start sharing your presentation.
Okay, sir.
So Aditya finished in time, so there's no issue with time for it.
Is my screen visible, sir? And am I
Yes.
audible?
Yeah, you're audible. Your screen is visible. You can start.
Just a minute, sir.
Go ahead, sir.
Sir, I just have to
Yeah, you can stop sharing
do
and
this.
stay again.
Yeah. Okay. Is it visible and am I audible, sir? Now?
Yeah, it is visible. You're audible.
Okay.
Go ahead.
Okay. A very good evening to all. I'm Dr. Soham Ranade, and at the outset, I would like to thank Bombay Orthopaedic Society for giving me this opportunity. The topic I will be speaking about today is evaluation of joint line in revision total knee arthroplasty, literature review on the intraoperative methods and clinical outcome. Now, why should we know about it? Joint line evaluation is like the forgotten puzzle. 80% of revised total knee arthroplasties have an elevated joint line. And this is because there is more emphasis on the removal of implants, balancing, and infection control. Also, there are arbitrary measurements. Sometimes they are not even considered. And there is lack of immediate awareness to joint line alteration. So the methodology which I used was there were electronic databases in PubMed and Google Scholar. I went across studies included from the last 10 years and also from the data from national joint registries. Level 1 and level 2 studies were taken for outcome measures. High citation index articles were taken and they were cross-referenced. So the data which I could obtain from joint registries were from United Kingdom, Germany, Finland, Belgium, Sweden, Australia, USA, and much of the articles from there I have cross-referenced with other articles. After reviewing the data and articles, I have put across the following objectives: literature review on the anatomical landmarks used for joint line evaluation, the calculations or the improvements which were there in the calculations in indices and ratios. Can we do anything preoperatively? What should be my cutoff? What is the big deal about joint line restoration? What are the patient related outcome measures and the problems which are faced? Any ways are there whether to tackle it? A peep into the future and concluding remarks. Now, historically, the landmarks suggested were 2 finger breadths above the tibial tubercle, 2 centimeters above the fibular head, 25 millimeters from the medial epicondyle, 22 from the lateral epicondyle, so on and so forth. However, all these parameters had particular problems. There was lot of male and female discrepancy, lean versus obese. There were ethnic variations, inter-observer errors were present, hence they were not good enough. Then came an era of meniscal scar tissue. People started advocating the remnant of meniscus as a surrogate for joint line evaluation. However, to much surprise, the samples which were sent off the meniscal scar tissue, they came out as fibrosed synovium, and therefore this was heartbreaking in the parameters obtained, and therefore even this was unreliable. Then came adductor tubercle as an important landmark in revision total knee arthroplasty for joint line evaluation. And even this stands true today. It is a good parameter. Much progress has been obtained in adductor tubercle parameters, and now they have found a common multiplier in the form of 0.53 multiplied to the femoral width to have a distance, perpendicular distance from the adductor tubercle for evaluation of joint line, as we can see in these diagrams. An Indian study from Sunshine Hospital started evaluating patients retrospectively in revision joint total knee arthroplasties. They also came up with a multiplier of 0.36 from the medial epicondyle and 0.31 from the lateral epicondyle, multiplied that with the femoral width, or also the transepicondylar axial width as it was called. So one step ahead to all these parameters was given by Servian et al., who started obtaining constant multipliers for multiple landmarks around the knee joint. Not just that, he also started obtaining posterior landmarks for posterior condylar offset ratio. So from the lateral epicondyle and the medial epicondyle, we have constant multipliers in the form of 0.28 distally and 0.29 posteriorly for the lateral epicondyle and 0.35 and 0.34 for the medial epicondyle. These are multiplied with the transepicondylar axial width. Another method which was obtained was from the tibial tuberosity. So he measured the tibial tuberosity and the AP diameter of tibia and proposed that the distance of the joint line is 50% of the AP diameter of the tibia or 27% of the femoral width. So now we have three reference points, one from the tibia, one from the distal femur, and one of the posterior femur. Now, all these parameters, all these ratios, whether they have an impact in the better evaluation of joint line, or is it just difficult mathematics? So no, ratios are definitely better, and they are giving better results as compared to gross distances which were used earlier. Now, how can we go about it? We can obtain routine CTs. We can do a MARS protocol, that is metal artifact reduction sequence, to evaluate the landmarks. Preoperatively, we can calculate the values by the different indices, enter the OT with a designated measure, as well as intraoperatively verify the outcomes which we have got. Now, in the early 2000s, a measure of more than 8 millimeter elevation of the joint line was associated with poorer KSS, that is knee society score. But as and how the data progressed, in 2008, a cutoff of 5 millimeters was given. In 2022, an article compared joint line elevation of more than 4 millimeters and less than 4 millimeters. And in this, we can see that the range of movement is significantly better for the less than 4 millimeter maintained joint line as opposed to the other. Another impact of negative effect of joint line elevation, as we can see as and how the joint line elevates, there is reduction in knee society function score. Now, all these articles, an average of 7-year follow-up, started giving prospective patellofemoral kinematics. Now, in this, an elevated joint line alters the patellofemoral contact force to such an extent that 15 millimeter elevation, as we can see in this red bar, there is 90% of body weight which is present, or the contact force applied to a single staircase climbing. And so that is not desirable. Another problem faced was mid-flexion instability. Now we can see here that the arc of motion of knee flexion does not coincide with the MCL flexion arc when the joint line is elevated. So between 30 to 60 degrees of knee flexion, there is mid-flexion instability. Another problem which was faced was patella baha and pseudopatella baha. To the left, we have patella baha with altered or lowered insal salvati and black-bun peel ratios. And to the right, we have a normal insal salvati and a lowered black-bun peel ratio, that is pseudopatella baha. Both these patella baha and pseudopatella baha the outcome measures were poorer at 1-year follow-up for range of movement being only 98 degrees for patella baha and 92 degrees for pseudopatella baha, as opposed to 110 for normal restored joint line. The pain score was also significantly higher for those of elevated joint line cases. Now, does it have an impact in liner wear? So yes, pseudopatella baha impinges against the tibial tray. That causes maltracking of the patella, and hence there is liner wear, so much so to an extent of 11.3 millimeter cube per year. Now, does the impact of joint line height restoration change with the prosthesis which we are using? So a difference between rotating hinge versus a condylar showed no statistical difference, but the use of offset stems have a significantly better impact in restoring the joint line. The modifications which we can use to restore joint line are meticulous evaluation of the joint line preoperatively and intraop confirmation can be done. Limited resection has to be done. Offset stems can be used. Use of wedges and augmentations can be used to lower the joint line. And there are company zigs which are also being advised now. They are also helping in evaluating of the joint line, one of which we can see here. The way forward is articles on robotics for revision total knee arthroplasty. Now, these articles are giving bony landmark registration with component in situ, and this can definitely increase the accuracy and help the surgeon in evaluating joint line intraoperative. The take-home messages are: we need to remember three figures. One is 0.53 for the adductor tubercle, a reverse of that which is 0.35 for the medial epicondyle, the distal part, and 3.4 for the posterior aspect. Multiply them with femoral width to have the joint line. Elevated joint line more than 4 millimeters leads to poorer patellofemoral joint kinematics, increases wear rate, anterior pain, and mid-flexion instability. Meticulous evaluation of joint line is necessary. Pre-op, intra-op confirmation, use of offset stems, wedges, and augmentation, and robotics are definitely a way forward, helping in accuracy of joint line estimation. These are my references. Thank you so much for your patient listening.
Thank you, Soham. You took 30 seconds more for your presentation. I'll invite the judges for their questions. These are some.
Who's going to ask the first question?
You, sir.
Okay, you talked about elevation of the joint line. Is there any problem or advantage if the joint line goes down distally?
Sir, in revision total knee arthroplasties, the depression of joint line has not been encountered in many studies because there is already a bone loss which is present. So there are no studies which calculate or evaluate the depression of joint line which is seen. It is restored, or so much so that there is elevation which is found to varying extent.
I'll come again. Dr. Dhar, you go ahead with the next question.
Okay. Soham, excellent presentation for a very difficult topic, which even we have not been able to fathom so far. My clinically means I want you to be clinically relevant to me at least. What you said, that adapter tubercle method, 0.54 or 0.53, whatever it is,
Yes.
means clinically, how do you check it? Means how do you,
Sir, yes, sir. Sir, what they have
on table, I
mentioned
mean
is,
to say.
yes, sir. Sir, on table, the adductor tubercle pointed as a prominent part at the flare of the metaphyseal flare, which we can see intraoperatively. We can evaluate the adductor tubercle there. So on the medial side, the flare at which it communicates the junction of the metaphysis and the epiphysis. So the point there can be known as the landmark, which we can use.
So you measure the width of the whole femur as well as the distance.
Yes, sir. So we measure the prominence of the epicondyles on the medial and the lateral aspect. So we get the femoral width or the transepicondylar width, and that we multiply by a constant multiplier which has been predetermined by series of cadaveric studies or ethnic variation studies,
0.54.
multiple MRIs, and that value is 0.53. So once we get the value, we can draw a perpendicular, or we can have a rough evaluation as to where the joint line will lie.
Okay. Something similar what Dr. D.D. Shah asked you. Suppose the joint line is shifted, how does it affect the stiffness or whatever, pain?
Sir, the
later?
depression
Literature, what
of
does
the
literature
joint
say?
line.
Because frankly, I never bother about, I just see my cuts. So how much does it, neither we do preoperative assessment nor we do so does it really matter? But what does literature and audits say?
Yes, sir. Sir, so because the joint line depression, this is in terms of revision total knee arthroplasty, sir. For revision cases, joint line depression, I have come across no article which gave an estimation of depression of joint line, because initially the cuts are taken in the primary knee arthroplasty. So there is already an elevated joint line, and that we have to distalize now. So once we remove the implants, once we take the femoral cuts further, there is further elevation of joint line as opposed to a primary TKR, total knee arthroplasty, and then that is brought down or brought to a level of neutral or a normal joint line. But a joint line depression in a primary knee also causes increased resistance to flexion. The flexion ranges are reduced, and that can be expected even in a revision case. But the articles are not present so far, which all convey
So
a
is the
revision case
relevance
scenario.
similar in primary as well as revision? So I always thought that revision it matters really.
Yes, sir. Revision it matters because there is higher propensity for us to err on the elevated side, because the bone loss is so much and it is not calculated as to what was the native joint line for that joint. Sometimes the joints are revised not just once but twice or thrice, and subsequently lot of distal femur has been removed over a period of procedures. Distal femur resections have been done for removal of the primary implant. There have been debridements done for infection. So
That is understood. So that is what I wanted to know. In primary, does it affect the range of movement if we are not very accurate?
yes,
Does
sir,
it?
it
What does
matters.
the in the primary I'm talking?
In primary also it matters, but the amount of elevation is not much. They say that up to 4 or 5 millimeters you can be in the safe zone. It doesn't matter so much within the 5 millimeter zone, but beyond 5 millimeters, the contact forces or the patellofemoral forces and the outcome scores significantly worsen. So a threshold of 5 to 4, which is obtained currently, which is followed now, is present, but it also affects the conventional or the primary total knee arthroplasty, even in primary.
Okay, thank you. I think Ashish can take.
Yeah, so
Yeah, Dr. Shah wants to continue.
Yeah, there were three methods you were seeing from adductor tubercle, and then so out of this, according to you or according to literature, which should be implemented?
Yes, sir. Sir, now according to literature, what people say is because we have a constant multipliers with us in our hand, we can have different values from all of these, and we can have multiple points which lie to form a single line of the joint line. So we can have one parameter from the adductor tubercle. All this can be done preoperative as well. So we can have a set value from the adductor tubercle. We can have values from the medial epicondyle, both distally and posteriorly, and the point where or the line where these 3 points coincide, that could form as the joint line.
Wonderful, good. Next,
right.
Ashish ji.
I just want to ask one more question before I take. Sorry, Ashish.
Yes, sir.
Means this is for again my curiosity. Like suppose I want to study my own joint lines now in TKRs. Is there any post-operative method that you can that whether you were right or wrong or as a matter of study? When Sachin is there, he'll write a paper very soon. So is there any way to assess or any view, X-ray or anything which you can do?
Yes, sir. In
This is just
the
out of syllabus for you. When I just wanted
yes,
to know.
sir. This is after
Yes.
primary TKRs.
Yeah, after primary. Yeah.
Okay.
As a
So-
matter of study, as a matter of audit.
Okay.
See that
Yes, sir.
80% times my joint lines are in position or within that range of 4 millimeters. Is there a standard radiological view or something which you should take? Anything from
Sir,
literature you could get?
Yes, sir. Sir, from literature, I could find two scenarios. One is when we are really lucky and we have a contralateral healthy side which is not operated, and that we can take as the native or the accurate measurement of the joint line. We can formulate. We can take knee, anteroposterior weight bearing, and lateral X-rays or CT scans of the normal side. We can have the ratios for that limb, and then we can reciprocate it to the operated contralateral side, and we can evaluate that maybe our joint line lies within the 4 millimeter cutoff zone or it is evaluated. If both are operated, then in fact, even after the total knee arthroplasty, if we can do an X-ray, we can have the markers that from the adductor tubercle on the X-ray, if we multiply by 0.56, we can get the cutoff for the joint line distally. So the
So does
same
varus
methods
or
can be
valgus
done.
affect it? Does varus or valgus affect it? No.
Sir, alignment strategies I haven't come across for revisions because there is no concept as such for revisions. But for primary, it will affect, sir, to some extent because the neutral axis is not perpendicular to the ones which we are taking.
Yeah.
The
Thank you.
native
Thank you
axis.
very much. Ashish.
Actually, sir, the similar questions have been asked by the previous two judges. I wanted to ask you: is there so? So, is there any paper or review on inter or intra-observer variation on recognizing adductor tubercle as a landmark?
Sir, there were inter-observation variations which were present, but that is the reason why they have come up with an array of investigations or an array of indices. And now the literature states that don't rely on a single parameter because there are chances that it may go wrong. So therefore, they came up with multiple factors as to for us to obtain the joint line.
So, if
So yes, sir. So
Sorry.
the variations exist, but they are not as common or as significant as to other indices which were used previously.
Right. So, if you are to do a revision, then would you try to identify the adductor tubercle using radiographs like intraoperative CM, or would you do it clinically? This brings me to the same question Dr. Dhar was asking, that it is not actually very easy to locate an adductor tubercle. You might locate the medial and the lateral epicondyle with certain amount of accuracy. But locating,
Yes, sir.
so what do you recommend, that we use a CM or we do it clinically?
Yes, sir. Preoperatively, we can know that by
Intraoperatively.
calculations. Intraoperatively, if we are not sure, we can of course take the help of a CM to know the adductor tubercle. But we can also rely on other parameters like the medial epicondyle or the tibial tuberosity, and then we can have an estimation of the joint line,
Because in
whether it coincides with the adductor tubercles.
because in the conclusion side, the formula that, or the multiplier you used was the adductor tubercle, right?
The multiplier was 0.56 from the adductor tubercle, and in medial epicondyle we have two multipliers, 0.35 and 34, both for distal and posterior.
Okay, so you can use either or, right? We don't need to use. So the point I'm making is that I think for me it will be difficult to locate the adductor tubercle very accurately. Okay, especially when you are exposing the knee, which is so fibrotic, taking out the implant. Medial epicondyle will be good because the bones, everything will be paper thin. So that's the
Yes,
reason
sir.
why I asked about inter and intra-observer variation in
Yes,
the
sir.
measurements. Okay, the second question was asked by Dr. Dhar, whether there was any study on contralateral limbs. I mean, you can easily use the contralateral limb to assess your measurements. In your institute where you did the study, is it a part of your dissertation, this study?
No, sir. Sir,
No.
while assisting, I usually had that doubt. How is my boss identifying the joint line? So that doubt I had asked him while I was assisting him. So he told me that it is better you do some thesis or
Study
some
known.
literature review on that, because it is not very clear and it is not frequently understood or operated on.
Good, good, good. Thank you very much, Soham.
Sachin,
Yeah, so nice presentation. Any role of CT scan pre and post in your study, like, because all are talking about the joint line adductor tubercle.
Yes, sir. Sir, in one of the slides, the flowchart mentioned, I had given that we can do a Mars CT, sir, metal artifact reduction sequence on the already operated knee to know the parameters before entering for the revision of the same knee. So once we have the pre-operative CT for the operated limb, we can know the parameters, we can formulate our own set of values, and then we can enter the OT and formulate and plan the joint line accordingly.
Do you include all the knees, like especially the bone loss or varus or valgus or stiff knee? Everything is included in this?
Sir, for revisions?
Yeah.
Yes, sir. Sir, multiple studies, they classically divided between the septic revisions and the aseptic revisions. So they found that the values of joint line elevation were much more for septic, which was understandable. And hence the restoration of joint line was much more important for those of septic. They essentially gave poorer outcomes, the septic revision cases, who had altered joint line more than 4 millimeters. So broadly, they have divided into septics and aseptics. With septics, more debridement, more bone loss happens, and therefore the migration of joint line is more proximally.
Okay. Okay.
just one question from me, Dilip Shah.
Yes, sir.
If you use robotic or you are going to use computer assisted, Can
Yes,
you
sir.
designate that the joint line will not be elevated more than 4, and how will you do it? 4
Yes,
mm.
sir. Sir, the role of robotics in revision total knee arthroplasty is upcoming. They have recently, this is about Mako, sir, robo which I read. They have launched a revision TKR software or a database which now incorporates the landmarks or the registration directly on the implanted TKR. When we open the joint, we don't need to remove the TKR before undergoing or before calculating for the bone loss and evaluating of the joint line. What they have done is they are taking landmarks directly on the implant, and based on that, they are evaluating the further cuts or the required joint line levels. The literature on that is lesser at present. I could have come across only 2 articles. Both were within a span of 1.5 years. One was last year and one was this year. So this aspect is yet to be discovered.
Well done. And may I request Ashok, sir, please give us also time that we do not overstretch the questions.
No, sir. I think question answers are important, and
Okay,
No,
wonderful.
I think it
lot of
is
it.
important that we ask as many to, that will
Yes.
help them in getting more marks.
That's
Yes.
wonderful. Yeah, Ashish.
Since we are questioning you on your presentation skills, what is the significance of the last slide that you have presented, Soham? I didn't understand it at all.
Sir, if we change the way we see at things, the things actually change. So, nazariya badal diya to things
Your
start.
joint line badal jayega, kaisa badalega? You are looking at your joint line in a different aspect. It's not going to change.
It's like me ना, हम लोग
So,
bother ही नहीं करते joint line, तो नजरिया बदल
so
दिया.
yes, sir, this was what I thought about that. So far, the importance to joint line was not given because even my sir
True.
was more focused on the balancing and the infection control. This was sort of a neglected or an ignored, so to say, a parameter, which actually gave long-term poorer scores. So this was just as a closing
I know your
slide,
previous
sir.
boss, by the way.
Sir?
He's also watching. Your previous boss is also watching.
Sir,
I'm just
I have
kidding.
consulted him, sir. I spoke with him last night, and he said, "Okay, go ahead."
Thank you.
Okay, thank you so
Thank
much.
you. Thank you. Good.
Okay, great. So we'll now give some time for judges to give the marks to Soham. Meanwhile, Mitali, you can start sharing your presentation.
So,
Okay, we can see it. Go full screen. Okay, we can see it. We can just unmute yourself. We can't hear you. You have to unmute yourself, Mitali.
hello, sir. Am I audible now?
Yeah, you're audible. So I'll mark the timer and you can start.
Yes, sir.
Go
Good
ahead.
evening. Good evening, everyone. I'm Dr. Mitali Mokashi, a senior resident from GS Medical College and KEM Hospital, Mumbai. Today, I would like to discuss about single bundle versus double bundle posterior cruciate ligament reconstruction. What is the current status? The posterior cruciate ligament is composed essentially of two bundles. A large anterolateral bundle, which acts primarily during flexion with a tensile strength of 1620 Newton, resists mediolateral translation, and a small posterior medial bundle, which acts primarily during extension with a tensile strength of 258 Newton, which resists anterior-posterior translation. The PCL can essentially be managed in 4 different ways. Conservative management for grade 1 and 2 injuries, anatomical single bundle reconstruction and anatomical double bundle reconstruction for grade 3 injuries, and tibia inlay technique, which is reserved for the revision cases. So the research question for today is that, is the consensus emerging on single versus double bundle PCL reconstruction? To address this, electronic database like PubMed and Google Scholar was searched with keywords like single bundle, double bundle, anatomical posterior cruciate ligament reconstruction with a filter of last 15 years. Level of evidence 1, 2, and 3, randomized control trials, systematic reviews, and meta-analysis were included. Studies with high citation index were preferred. The outcomes were studied with respect to the biomechanical stability in cadaveric studies, in which the posterior tibial translation, external rotation, varus rotation, and coupled external rotation were considered, and clinical studies with respect to the subjective and objective clinical scores, radiological outcomes, and failure rate. Coming to the biomechanical stability, the posterior tibial translation was found to be significantly less in the anatomical double bundle PCL reconstruction as compared to the anatomical single bundle reconstruction in a study by Wijdix et al. Similar results were echoed in 8 other studies at 10 degrees, 30 degrees, 60 degrees, and 90 degrees of knee flexion, with a p-value showing a significant difference favoring the double bundle PCL reconstruction. With respect to the external rotation at 10, 30, 60, and 90 degree, there was a preponderance towards stability favoring the double bundle. However, this difference was not significant. With respect to the varus rotation, again at 10, 30, 60, and 90 degree, the double bundle fared slightly well than the single bundle. However, the difference was not significant. Coupled external rotation was measured at variable degrees of angles ranging from 0 degree to 120 degree, where posterior tibial loading, that is the posterior drawer test, was given and external rotation was assessed. Again, no difference was found significantly between the anatomical single and anatomical double bundle reconstruction. With respect to the subjective scores, at 2 years of follow-up, the postoperative Lisholm knee score showed no significant difference between the single and double bundle. The Tegner score as well showed no significant difference. These results were echoed at a 10-year follow-up with no difference between the single bundle and double bundle reconstruction in the Lisholm score or the Tegner activity score. The objective scores, however, showed a significant difference with better scores seen in double bundle reconstruction in level 2 studies. However, an analysis of level 3 studies showed that the difference between single and double bundle was not significant. At a 10-year follow-up, the International Knee Documentation Committee score favored the double bundle group with a significant difference in a level 2 study. The TLOS 90 score was only measured at a 2-year follow-up in the review of articles and was found to be significantly better in the double bundle group. With respect to the stability was measured with KT 1000 arthrometer, with side-to-side difference in measurement being measured. At a 2-year follow-up, the stability was significantly better in the double bundle group as compared to the single bundle group. At a 10-year follow-up as well, with the arthrometer, the stability of a double bundle PCL reconstruction was better than a single bundle PCL reconstruction. With respect to the radiological outcomes on posterior stress views, the double bundle group showed posterior translation, which was smaller than that of single bundle group at 2 years follow-up, and this difference was significant. At 15 years follow-up, the side-to-side difference and the progression to osteoarthritis was not significant, however, between the single bundle and the double bundle groups. The failure rates, the 5-year survival rate for single bundle was 85.7%, double bundle 94.4%. At 10 years, single bundle was at 82.1%, where double bundle was at 88.9%. The 15-year survival rate of single bundle was 82.1%, whereas double bundle was 83.7%. The Kaplan-Meier survival curve was assessed, and the difference between the failure rates of single and double bundle PCL reconstruction were found not to be significant. In conclusion, biomechanical studies show that double-bundled PCL reconstruction is superior to single-bundled PCL reconstruction. The objective scores show that double-bundled PCL reconstruction is better than single-bundled PCL reconstruction. However, the subjective scores, the survival rate, and the long-term clinical outcomes suggest that single-bundled PCL reconstruction is equivalent to double-bundled PCL reconstruction. So, the double bundle may be preferred over the single bundle, where early return to sports is desired because it is biomechanically stronger. Long-term outcomes, however, show no difference in subjective scores, and more level 1 evidence clinical studies are necessary to determine the absolute superiority of one technique over the other. These are my references. Thank you.
Thank you, Mitali. You finished 30 seconds ahead of time. We'll invite questions from judges now. DD Shah, sir, you can go ahead.
Yeah. Thank you very much for putting me in this wonderful presentation. My question is, how easy is it to do single bundle and how difficult is it to do double bundle?
So, sir, once we are trained appropriately, the double bundle posterior cruciate ligament is slightly easier to perform than the double bundle anterior cruciate ligament, given the large femoral footprint of the posterior cruciate ligament, which is almost 200 millimeters square.
So if it is easy also and it gives you a better result from two determinations, then why is it not common to do double bundle and still you have to compare with single bundle?
Sir, because initially the studies before 2010 suggested that the double bundle and single bundle posterior cruciate ligament had similar efficacy. So we were working on those lines. The newer studies which have come in have shown that biomechanically, the double bundle PCL reconstruction is superior to the single bundle reconstruction. Also, sir, when we are performing a double bundle PCL reconstruction, we require two grafts. As per an article by Laprade in 2018, for the anterolateral bundle, the quadriceps tendon with a bone plug should be preferred, and for the posteromedial bundle, the hamstring can be preferred.
Now, if you don't do PCL reconstruction and in a day-to-day activity who is not a sportsman, will
Yes,
it
sir.
matter?
I'm sorry, sir. The question is conserving a PCL versus PCL reconstruction?
Yes, and in normal sedentary worker, not a sportsman.
Okay, sir. So the guidelines and systematic reviews suggest that a posterior tibial translation of more than 8 mm on a posterior stress radiograph warrants PCL reconstruction, and the results with PCL reconstruction are far superior to not reconstructing the PCL, and it is statistically significant.
That's good. That's enough from my side. May I request Dhar sir?
I'm not an orthoscopy surgeon, but anyway, just for the sake of asking questions, how difficult? No, he actually asked you. I wanted to ask, as you said, in the long term, the results are more or less similar.
Yes.
So would it matter sort of in an athlete who is a high intensity athlete or a person like sedentary worker? Would it matter whether you do double bundle or single?
Sir, as
Any
per
difference in the profession or the activity level?
Sir, as per the current evidence we have, in the long term, it would not make a difference. But given the profile of an athlete or a sports person, he would want earlier return to sports and better stability of the knee when he returns to sports. So I think that we could, as per the studies, we can give better with a double bundle reconstruction. However, in a sedentary worker who is okay with a little instability and posterior tibial translation, maybe it should not make a difference, is what the review of literature suggests.
So does even a post-op protocol change in these the two?
No, sir. The studies which I have evaluated had the same post-operative protocol for double bundle and single bundle reconstruction.
Thank you. That's all.
Thank you.
Right. So Mitali, good presentation. I have a few questions.
Thank you, sir.
These papers which you have reviewed, okay?
Yes, sir.
And the graphs that you have presented, which favor the double bundle over single bundle.
Yes, sir.
So they were, let's say, between 6 to 8 studies that they have arrived at. What sort of patient population are they looking at, number-wise? How many
Number-wise,
patients? Yeah. Is it a
the
study
number
of
of
thousands of patients or study of a few hundred or few 50?
no, sir. No, sir.
How
20
much
to
is it?
40 patients.
20 to 40 patients in each study. Secondly,
Yes.
have you
In
noticed?
each group in each study.
Yes. And how many of these would you say were very well constructed randomized control trials?
Sir, 3 of them were level 2 evidence randomized control trials. A study from 2014 by Lee et al., a study by Yoon et al. And Wang et al. In 2014 and 17.
And is there a sort of a systematic bias in these? I mean, are they coming from specific institutes that you have noticed? Are they coming from North America, China, Europe, or
Uh,
Asia, or any other part
so,
of the
so
world?
the 3 level 2 evidence studies were one from the US, one from Korea, and one from China.
Okay. Are these published in very good journals?
Yes, sir. They were published in the American Journal of Arthroscopy, the American one, and others had level 2 evidence is what I had checked, sir.
Okay. Right. Secondly, so you mentioned that, objectively, yes, double bundle, I see from the graphs, objectively, double bundle is more mechanically stable and sound.
Yes, sir.
Uh, is there any effect? Have the authors mentioned that there is any effect of any associated lesions like posterolateral corner repairs or any associated reconstructions that have been done with PCL, which also influence the choice of grafts and the choice of the procedure? Is
So,
there
the studies which I visited had mentioned that multi-ligament injuries were always excluded. So they have considered isolated PCL injuries. However, the meniscus injuries have not been documented in those studies. So we need better level 1 evidence prospective clinical trials further on this subject.
Okay. So tomorrow, let me just put your question. So in the short term, subjectively, even in the short term, you said subjectively, there's not much of a
no difference.
Yeah. So for a sports person also, for a surgeon who's less skilled, probably an average set of skills, for him to offer also a single bundle would not be a bad option to give. Is that right?
Subjectively, it wouldn't be, sir. But objective scoring and given the instability, posterior tibial translation wise, maybe it would make a difference.
Okay, excellent. And is there, see, when you mentioned that when Dr. Didi Shah, he asked you that why was it not popular? Why is it not caught on? You mentioned that these are the procedures which have been designed after a period of time. I think 2012 onwards, these have been becoming more common.
Popular.
Comparisons, are they historical comparisons or are they real-time comparisons? I mean, is it the same set of surgeons who have done double bundle and single bundle both, or they have compared a set of surgeons who's the double bundle and comparing it to historical comparisons or someone else's studies?
So the level 2 evidence studies were all prospective randomized control studies, and the level 3 evidence studies I considered were retrospective case control studies. So probably, as I mentioned in one of my slides, in objective scoring also, there was a significant difference in the level 2 studies. However, level 3 studies showed no significant difference.
Okay.
One question.
Yes, sir.
I wanted to experiment in arthroscopy. So is there any study where they study the proprioception like we do CR knees and PS knees? So in double bundle and single bundle, any proprioception changes, or was there any study on happy knee or something like that?
In my review of literature, sir, I did not come across that. But however, the international knee documentation score does take that into consideration.
Thank you.
Thank
you. Mitali,
yes.
Good presentation.
Thank you so much.
Like most of the questions are asked. So roughly, any role of peroneal longus graft, because which graft normally is put? You're saying hamstrings and predominantly any role of peroneal longus graft in your PCL reconstruction double bundle?
Yeah. The review of articles I read, most of them considered allografts. So tendo Achilles allograft was preferred for the anterolateral bundle, and a peroneus longus allograft was considered for the posterior medial bundle. However, if we are not comfortable with allografts, autografts may be used. I have not read any articles which use the peroneus longus for PCL reconstruction. They mostly use the quadriceps and semitendinosus graft. Maybe it would be of more help during a revision scenario if required later.
Yeah, the period of the question was that on a revision or a multi-ligament. In this study, you are not only taken isolated PCL, right?
Yes, sir.
And roughly the literature data you've shown is of only a short duration, not a
Yes,
more
sir.
duration.
Yes, sir, because the studies were had conflicting outcomes before 2010 and after 2010. Hence, as per the guidelines, I have considered only the recent studies, sir, for my
So
analysis.
your conclusion is double bundle is always better. Any role of only single bundle, which patients it will be good?
Sir, subjective outcomes, there is no difference between single and double bundle. So as Dharsar pointed out, a patient who has a sedentary lifestyle would probably benefit from a single bundle posterior cruciate ligament reconstruction also.
Okay, thank you.
I come back again. When I asked you a question, which one is easier? I feel that maybe I have understood wrong. You said double bundle is easier?
No, sir. I said that as compared to a double bundle ACL reconstruction, a double bundle PCL reconstruction is comparatively easier because of the larger footprint.
Okay, but if you were to do single bundle, it will be easier, right, for posterior cruciate?
Sir, I haven't found any literature which suggested that it is technically easier. However, if trained appropriately, it is the footprint is large and there is a groove between the anterolateral and the posteromedial bundle on the femoral footprint. So if trained appropriately, it should not be very difficult, sir.
So if at all you have to tackle any PCL,
Yes, sir.
would you go ahead? Will you do double bundle always, or you will scrutinize and depending on sedentary worker, you will do single bundle, or in professional athlete, you will do double bundle?
Thank you for your question, sir. Given the current evidence, which shows that subjective outcomes are not different, and the biomechanical outcomes are different, I would scrutinize as per you said, and in an athlete would go for a double bundle, whereas in a sedentary worker may go with a double bundle or single bundle, whatever the patient desires.
I have finished from my side, and if anybody wants to ask a question, please.
No, I think we can go ahead with the next candidate.
Thank you.
Thank you, Mitali. Great presentation. And judges can give their marks.
Sure.
I'll invite Dr. Nihar Modi for sharing his screen.
Thank you, sir.
Nihar, go ahead and share your screen.
Thank you. Is my presentation visible, sir?
Yeah, your presentation is visible and you're audible. You can start.
Okay. A very good evening to one and all. Firstly, I would like to thank BOS for giving me this opportunity one more time to talk on this platform. I am Dr. Nihar Modi, and I'll be talking about management strategies in first-time traumatic anterior shoulder dislocations. So the shoulder is the most commonly dislocated large joint of the body owing to the difference in the humeral head and the glenoid size. It has maximum mobility and range of motion, but in the quest of maximizing mobility, joint stability is always compromised. A good interplay between the static and the dynamic stabilizers is required for a well-balanced glenohumeral joint. The static stabilizers include the labrum, the joint capsule, the glenohumeral ligaments. The negative joint pressure helps in concentric reduction of the humerus in the glenoid too. Dynamic stabilizers like the rotator cuff and the scapulothoracic muscles are very important in maintaining the stability. So 90% of the shoulder dislocations are anterior, and the maximum incidence and recurrence of shoulder dislocations is in the second and third decade. This is probably due to the fact that as age increases, the level of activity goes down, and also the collagen stiffens as age increases. Hence, there's a reduction in incidence of dislocations beyond the second and third decade. Also, dislocations beyond the age of 40 to 60 are associated with rotator cuff tears. In a first-time dislocation, 96% of the time, there's an isolated Bankart lesion. And with further dislocations, it could be a double lesion, triple lesion, or a quadruple lesion with poor and worsening labral morphology. With respect to the bony lesions, in a first-time dislocation, 64% of the times, there's a Hill-Sachs lesion on the humerus. A bony Bankart lesion is relatively a little rare to have in the first time, but with increasing dislocation, the glenoid bone loss does increase. So multiple dislocations create micro-instability, which exacerbates the bone and soft tissue loss. This often necessitates salvage procedures in the long run. Hence, to prevent these dose-dependent effects of multiple instability, early surgical stabilization is advocated. In spite of this, the management of a first-time traumatic anterior shoulder dislocation continues to be a controversy. On a lighter note, we probably would not have been discussing this topic over here if management of shoulder dislocation was this easy. So let's see what the literature has to say. I did a study where electronic databases were studied for the last 10 years. A PubMed search, a Google Scholar search, and relevant cross-references from these articles were taken. Systematic reviews, meta-analysis, and randomized control trials were included, and all articles had a high citation index. I included patients with first-time traumatic anterior shoulder dislocations aged between 15 to 40. All studies had more than 1 year follow-up, and cases with multidirectional instability, voluntary dislocations, and cases associated with cuff tears were excluded from the study. I've divided my presentation into two parts, where I'll be talking about outcomes of surgical stabilization of a first-time dislocation versus conservative treatment with respect to the mentioned outcomes. Additionally, a few critical points and debatable topics related to the conservative management based on method and duration of immobilization will be talked upon. So coming to the outcomes, a systematic review of meta-analysis was done in 2020 and 2023, where they found that arthroscopic bankard repair of a first-time traumatic anterior dislocation proves to be superior to conservative management with reduced recurrence, increased return to sport, and further surgical treatment for shoulder instability. A meta-analysis was done in 2022, which also compared short-term and long-term results, which showed significant risk reduction in shoulder instability in the long-term as well as short-term. This is the largest and most recent meta-analysis by Cutteridge et al., which showed better outcomes with surgical stabilization of a first-time traumatic anterior dislocation. With respect to future arthritis, a level 1 study with a 25-year-old follow-up followed up these patients where a first-time traumatic shoulder dislocation was operated on day 1 versus a conservatively managed one. And in the conservative group, 39% of the cases, which was significantly higher than the operatively stabilized, had a higher risk of arthritis. DiCarli et al. Also found out that non-operatively managed patients in the long run do have a higher risk of arthritis. In 2024, 2 level 2 studies were done, which showed that arthroscopic bankard repair on day 1 has upfront higher costs with surgical stabilization, but in the long run, they prove to be cost effective. So when I talk about this literature, it feels like it's an open and shut case. It's in the favor of surgical stabilization of a first-time traumatic anterior dislocation. I came across a very interesting line which says literature is good, but literature takes you where you want. So let's see the other side of the coin. For example, if we take this study by Hovelius et al., where he studied non-operative treatment for primary anterior shoulder dislocations, he showed that in age less than 22 years, there was a 55% recurrence rate. This means that if there are 100 patients and we consider 55% recurrence, we consider all patients to be operated on day 1, 55 patients will benefit, but 45 unnecessary surgeries will be done. Robinson et al. Gave a very interesting opinion in a study where he said to prevent 1 patient from sustaining a further radiographically confirmed dislocation, 4.6 patients will need to be operated. 2 studies were done in 2020 and 2010, where they showed that the bankard repair after the first dislocation versus bankard repair after recurrent episodes, although less than 5 were compared, and they showed there were no difference in outcomes with respect to recurrence and complications. If we consider arthroscopic repair for all cases, we also need to keep in mind that complications of surgeries do occur. And even after a primary bankard repair, the rate of shoulder instability is 13 to 15%. Let's talk about the conservative treatment debated topics. So initial studies said that immobilization and external rotation, as you can see in this video, tightens the anterior soft tissue, which promotes better coaptation of the bankard lesion to the glenoid neck. Itoy et al. In his initial studies showed that immobilization in external rotation had significantly lower recurrence. This was in 2003. However, in 2009, 2 level 1 studies were done, which showed that there was no difference in outcomes between the method of immobilization. Also, immobilization and external rotation had very poor compliance. Traditional teaching taught us that after a first-time dislocation, you immobilize it for 4 weeks. But level 1 studies were done which showed that sling for 4 weeks versus sling for 7 to 10 days was compared, and they found there was no clinical benefit of a prolonged immobilization. So I would like to say there is no single answer for primary stabilization versus conservative management for a first-time dislocation. It requires a patient-specific approach, a shared decision between the patient and the surgeon. However, we should consider primary surgical stabilization after the first dislocation in high-risk cases like age less than 25, athletes and patients involved in contact sports, and if there is significant bone loss. With respect to conservative treatment, if trying for a conservative treatment, 7 to 10 days of immobilization till the patient is pain-free is adequate, followed by a physiotherapy regimen, and immobilization in internal or external rotation has equal outcomes. These are my references. Thank you.
Thank you very much, Nihar.
Thank you.
We'll invite Dr. Didi Shah for questions. You finished in time. So
Nihar,
Yes, sir.
a very excellent point of view you have drawn, and I would ask you a question that if it's a first-time dislocator, young, but then if you do surgical treatment, then it is like an overkill because 45% would escape from getting second dislocation.
Agreed.
So do you come to a resolution that second time dislocator you should do surgically, or you wait till they get recurrent dislocation?
No, sir. So if there is a second time dislocation, considering this is not an athletic patient, considering this is not a high demand patient, because if it's that, I might offer a first time dislocation. So if I'm getting a second time dislocation, I will definitely explain that now there's a chance of higher recurrence. And with progressive recurrences, the bone loss also might increase in the glenoid. So instead of a standard Bankart repair, you might have to end up with a Latarjet, which is going to be more morbid, and the return to sport and his outcomes after that will be inferior. So I would like to say I'll conserve a first time, and in the second time, I would definitely explain all the risks and offer a repair at that time.
Wonderful. Now I want to ask you that if you have done first dislocation and surgery, there are 15 to 20% chances of redislocation.
Right, sir.
What were the types of surgery done? Do you have any details about it?
So in the study I mentioned, sir, it was an arthroscopic Bankart repair which was done. It was an isolated Bankart lesion, and the primary surgery was done, and even after that there were 15% chances. So also many factors influence this, because if it's a high level athlete, there will be higher chances of a redislocation. If it is a ligamentous lax patient, which could vary with the patient selection, they also do have an increased chance of dislocation. But yes, my point to make is that even when you're doing it on the first time, you need to tell the patient that there is a 10 to 15% chance of redislocation.
You said that there is no difference whether you immobilize or you give a sling.
No, sir. What I was trying to say is there's no difference whether you immobilize an internal rotation or external.
Yeah, that I understood. No, but then at one point you said that you just put it in sling. And then another slide showed that you at least immobilize for 7 to 10 days. So can you on that point?
So the method of immobilization was sling, which I was talking about. There were two aspects. One was internal, external, and the other aspect was whether we need to keep it for 7 to 10 days till the patient is pain-free, or keep it for 4 weeks. So recent studies say that you can keep it for 7 to 10 days till the patient is pain-free. After that, start range of motion exercises, then do resistance training, then do sport-specific physiotherapy, and then you can resume activity.
Good. May I request whoever wants to take up, or may I suggest Dr. Sanjay Dar?
Yeah, thank you, sir. As you, the last question, probably immobilization in primary dislocator, first time dislocators. Means I remember when we used to immobilize for 6 weeks, then now it is generally 1 to 3 weeks. And as you said, the shorter immobilization have probably the same results. There is a school which also says that immobilize in external rotation.
Right.
So what have you based it on a meta-analysis, or is there few reports? Is there a proper 1,000 patient study or something? So what is your evidence base? Because that was your topic.
Yes, sir.
So what is the evidence, or a Cochrane review or something like which can sort of recommend?
So as
good for our learning also.
Right, sir. So as I mentioned in my presentation, Itoy et al. In 2003 it was a level 3 study where he said immobilization and external rotation is good. But in 2009, there were 2 level 1 studies which were done. They were level 1 studies with a 2-year follow-up, which showed that either mode of immobilization, internal or external, is absolutely equal. And also, if you would logically think immobilization and external rotation is very difficult because he may not be able to carry out his daily activities. And in many cases, what happened is these patients were told to immobilize an external rotation, but after day 2 or day 3, they were just switching back to internal rotation.
But the evidence, the literature doesn't show that there's any benefit. That's what I wanted to know.
There's no benefit.
Suppose I convince somebody to keep it. Does the literature show that it has benefit,
No benefit.
or it heals faster?
No benefit. Not at all.
Second, does the rehab later, suppose 3 weeks, is there any evidence that this is the program, this is the protocol, algorithm, that what is the rate of recurrence in cases of rehab which was done differently in literature? Is there any literature on that, like scapular stabilization, this and that, whether they have benefited much better? Or and second question would be like, is there any algorithm for investigation? Like, would you like to do CT in first case itself, first day on itself, so that you realize that you want to do primary fixation, primary early stabilization?
Right, sir. So regarding the first question, the studies which are done in the methods, it was mentioned that all conservative treatment had a standard physiotherapy protocol for 3 to 4 months. All included range of motion, resistance training, and scapular stabilization. So there was no difference over there. So according to that, if most physiotherapy protocols vary, but more or less they have the same contents. Like it might vary by a week or 2. So those aspects were not specifically spoken about in literature. And to answer, sorry, could you repeat the second question?
No, so is the evidence very strong in favor of this? That's what I wanted to know. If we are recommending something on evidence-based, then the recommendation is very strong that a good post-operative protocol like this would definitely make a difference. Does it? Do the audits or any evidence reference show you that?
Yes, sir. So one study in 2022 showed that a physiotherapy protocol was required for, if you're conserving a patient, you need a proper physiotherapy protocol before you return back to sports. So according to them, the ideal was that after you immobilize for 7 to 10 days, you have to go in order. First, range of motion exercises, then you do resistance training. Only after that, you do sport-specific strengthening. Then you get back to sports. So if you're going to break this chain, the results are going to get affected.
Okay. Second question was preoperative investigation, like primary investigation. When a dislocator comes to me first time, do we take the routine x-rays like that? Does that really help to decide whether you should do surgery primarily or you should wait? So are there any red flag signs or anything with literature?
Yes, sir. So when a patient comes, we do get an X-ray, but in the first time, it is desirable. Literature says it's desirable to get a CT scan as well as an MRI scan. CT scan, why? Because if it is a bony Bankart lesion, yes, you're going to counsel him for operative. If there is a critical bone loss, yes, you have to go for an operative procedure. There's no debate between a conservative and a
So CT scan should be a primary investigation in all cases? No.
Yes.
There's no evidence.
Yes. Literature
says...
in
spine, now we do MRI. Earlier we used to do CT scan. Now we are doing MRI primarily to know the PLC complex.
Right.
So similarly, is CT a necessary investigation? What does the literature say?
Yes, sir. CT and MRI both are necessary investigations.
In the first visit?
In the first visit, yes. Yes.
Okay.
Because
thank you.
MRI, I would like to add, so even in an MRI is also very important because if you get like a 45-year-old, you may not have a labral tell you might have a rotator cuff lesion. So you're dealing with something completely different. So an MRI is essentially very important. And in 3 weeks, like if we are thinking about conserving and looking at it after 3 weeks, according to my understanding, a labral healing is not going to show up in 3 to 4 weeks.
So normally we are very happy. Once we reduce, we tell them go away, come back after 3 weeks, maybe 6 weeks. And then we don't bother till they just come second time. So that period is very important. So that is what I wanted to know, the evidence.
Yes. And doing these investigations on day 1 will help you give him the prognosis better, explain how much chance of a redislocation is there. Because if there are significant red flag signs on the MRI and CT, you can counsel him accordingly. And not every patient is open to a surgical procedure on day 1. They honestly want to listen to the fact that a non-operative would do. So you can counsel them accordingly.
Excellent. Thank you.
Thank you, sir.
Yeah, so that brings me to my next question, which you just mentioned, red flags. So I wanted to ask, you did not mention about how do you profile a patient who's going to, amongst those 55% of the people who are going to dislocate, the youngsters who are going to redislocate, can you profile them? I mean, is there any, I mean, does the literature say anything about having one more associated lesion, a large Hill Sachs, a bony Bankards, or an associated other tear, or a right hand dominance, or a prior history of a previous a contralateral shoulder dislocation which was operatively managed? So have you found anything of that sort in the literature? That is the
Right.
first question. And secondly, second question you can answer later on. You are mentioning, putting a heavy emphasis on that A.G. et al.'s paper on external rotation, which was published way back in 2003. I think one of the instructions given to you was we want recent references, isn't it?
Right, sir. So, okay, I'll answer the second question later. The first question is that, yes, sir, there are many red flag signs where you need to consider operative, which is age less than 25, a male involved in contact sports, and if there is significant bone loss. After that, if you counsel him for an operative, then of course you need to see if it's an off-track lesion or an on-track lesion, and then decide the method of the surgical procedure which needs to be done. So,
what I was wanting to ask is, so as both Dr. Shah, Dr. Dirisha, and Dr. Dhar mentioned, that 55% of the people, or let's say 45% of the people, are not going to redislocate again. We are talking about the youngsters.
right.
Among those 45, how do I identify whether my patient is going to be among 45 or 55, or do I give him the benefit of follow-up and ask him to see me after 1 month? So, are there any pointers based on the literature review that you have done that you can tell me that, sir, this is what I think is going to be a recurrent dislocator?
Right. So that is exactly what the future studies need to address, because if there is, these studies included multiple patients with multiple backgrounds. So in that 55, I don't know how to identify those 45. I just know what the risk factors are. I know that age less than 25 is a risk factor. I know males contacts was a risk factor. So I need to counsel the patient here, and there are algorithms, but it's very difficult to identify who are those 45 people. If there's a combination of less than 25 but non-contact sport, how do you, is there a short algorithm answer? No, it has to be a patient-based decision. And related to the question, the older paper question, sir, these papers, I mentioned that because they were seminal papers, and in the guidelines were mentioned that if it's required, you do mention. So that's how I started. That initially, actually, it was a new learning for me also, that immobilization, external rotation used to be beneficial, because I have seen everyone immobilizing in internal rotation only. So that's why there was a mention of that paper that external rotation initially they said is better, but all studies later after that refuted that finding, and they said it does not make a difference.
Was there a study done in Bombay on this external rotation versus internal rotation? The literature review?
I don't know, sorry.
You're from KEM, right?
No, I'm from, my post-graduation from JJ, sir.
Yeah. Okay, so in one of the previous virals, there was an anatomical study from the city of Bombay, from KEM. Dinshaw had done it, and he had followed up with this thing. I think, yes, it was before 2008, where he had taken cadavers, sectioned them, created a Bankards lesion, and shown them on an MRI that on external rotation, actually the lesion opposes. So these days in AJSM and American journals, they are publishing, they are revisiting that immobilization and external rotation.
Okay.
So we do get braces nowadays with those pillows which can keep the hand in external rotation, which can immobilize in that.
Right. So in 2003 also, sir, Itoy et al. Had done an MRI study. In 2001, he did a clinical study, and in 2003, Itoy et al. Did an MRI study as you described. Same thing. All MRI findings showed that the opposition was better. So it has a rationale definitely, but the outcomes in the later studies in 2007-9 definitely show there is no difference. So my point is, why trouble the patient, give him such a poor compliance external rotation brace, and if there are equally outcomes, why not immobilize an internal rotation?
We always immobilize the external rotation here.
I mean, what?
Yeah, so there is so you get a, anyway, that's not for the purpose of this discussion. There are braces and pillows available which will keep your hand in a slight amount of external rotation. Anyway.
Nihar, nice presentation.
Thank you.
Regarding the role of MRI, you said,
Yes,
do you think it is not an overkill doing MRI CT for all patients, and can the MRI showing you false positive reports, like maybe false positive, like a lot of hematoma, blood collection?
right, sir? So doing an MRI, I do not think is an overkill personally because of 2-3 reasons. One, if suppose you have a labral tear which is straight going up to the biceps, it's a no-brainer. You have to operate. So you have to see whether labral tear is there. You have to see if there's a bony Bankart lesion, if there's a cuff lesion. So it helps you to explain the prognosis to the patient also if you're planning a conservative. And on day one, you know that if there is a significant red flag lesion, why not operate, get the best results? Because initially the capsule is lax. After a month, after 2 months, if there is a redislocation, the capsule also becomes stiffer. You need more releases. Might be an inferior outcome that after that. So yes, traditionally there was actually, in fact, Sood et al. In armed forces, there was a paper in 2003 where it was an Indian study which was done where they reviewed how all surgeons are doing this practice regarding shoulder dislocations. So they showed that only 60% of the surgeons recommend an MRI and 40% of the surgeons recommend a CT for a first-time dislocation. But seeing that was a level 5 study that was just stating facts on how surgeons operate in India. But the trends in US, Germany, Europe, everyone, they all do an MRI for sure on day one.
And any role of like you do day 1 or day 3, like surgery is predominantly the first. So do you have any protocols? Like doing a day 1 would be more like more difficult, especially the hematoma and effusion all around soft tissue and other injuries?
So opinion again is divided about that, whether you should do a day 1 or wait for some time and then do it. But I feel that letting the hematoma settle, letting the effusion settle, and then doing it after a week or 2 once the patient gains his range of motion back would be better, because the post-operative physio will also be better, is what I feel. But I think I'm not a very big expert in this field. So from what literature says, people are completely divided about this.
Again, the Didisha sir's question, when a 25 years male patient comes to first time dislocation, you will do CT MR and you will operate? Because Rohit Sharma is doing quite well with dislocations.
So that is a completely different topic, honestly. I will have to see his MRI and wonder, because in his case, what happens, a trauma dislocates his shoulder, but he can relocate it back. So honestly, I am unaware of what the exact situation is. But and also it is influenced by an athlete if he's in sport, because if he's getting operated, he's out for 6 to 9 months for sure. So there are many different decisions which influences. In fact, Dickens et al. Had conducted a study where he compared that in season and off season repair outcomes in athletes. So there are many factors which it all depends on the patient finally. Like our job is to offer what is right. It all depends on the patient at the end.
Okay, good.
Thank you, sir.
Okay, thank you, Nihar.
Thank you, sir.
We'll request judges to give marks to him while I invite the next presenter, Dr. Abhishek. Abhishek, you can share your screen and get ready.
Am I audible, sir?
Yeah, you're audible and your screen is being seen. You
I'll
can
start. So my topic for today is extra weight, extra care, the obesity arthroplasty connection. I'm primarily going to talk about the total knee arthroplasty. We often see these x-rays coming into the OPD and we often wonder and have a bunch of questions in our mind when you see these patients, like what are the infection rates like? What is the aseptic loosening and revision rates like? Is there a strict BMI cutoff to be followed before offering total knee arthroplasty? Bariatric surgery or TKA, what comes first? TBL stems, are they in fact mandatory? And what is the pre-optimization going to look like? And why these questions are important is because by 2029, 69% of your primary total knee arthroplasties will be performed on patients having obesity or morbid obesity. 56 crore patients right now are obese in India. When I say obesity, I mean obese class 1 and 2 in the WHO classification. And when I say morbidly obese, it means BMI more than 40 in the obese class 3. Obesity predisposes you to osteoarthritis with the help of altered biomechanics and meta-inflammation, which is the adipokines that cause cartilage destruction. And we know of complications in morbidly obese. Let us discuss them one by one. We look at this site and we are often dreaded by it. But it is true that superficial infections are twice as much in obese patients and deep infections are thrice as much, multiple studies proving the same. Jameson et al. In 2012 did a single center analysis of over 4,000 knees and found that the infection rate is almost 5 times in morbidly obese patient. What is interesting about this graph is you have diabetes, but your BMI is in control. Your 1 year prosthetic joint infection rate is about 2% versus when you are 40 and above, it hovers over 10%. Again, aseptic loosening and revision rates, BMI over 40 had a 5 times focal osteolysis in radiographs, and obese patients had higher failure rates according to Foran et al. We are also looking at implant malpositioning, where technical errors and malposition of the component were 3 times as much in obese patient as compared to the non-obese ones. And Reiter et al. Did a 2011 study of 6,000 knees, and he found out that malalignment was significantly more in obese, and that too more in patients with BMI more than 40. We are also worried about extended lengths of stay and cost of hospital services, and multiple studies showing that super obese patients are a problem. And sometimes the weight does get critical, and we're looking at obstructive sleep apnea, hypertension, sudden risk of death, venous thromboembolism. These are all known complications with morbid patients. But what is the Indian scenario like? This is the graph from Indian Society of Hip and Knee Surgeons showing that the average rate of BMI with which we operate is around 29.1, and we seldom offer surgery to patients who are above 40. Agarwala et al. Studied 402 knees with a 1-year follow-up, but he said that the outcomes same for an obese and non-obese group, but capped the BMI for surgery at 39.9. Gaurav et al. Also in 2024 did a study in which he studied BMI does have a positive correlation with the post-operative scores, but they are not significant. So is there a strict mandate cutoff? Definitely there is a cutoff with BMI more than 40 because the complication rates do outweigh the benefits of total knee arthroplasty. This is in a 2013 extensive literature review. But what do the surgeons think? A 2021 survey of the American Hip and Knee Society surgeons found that 50% would keep the BMI at 40, 25% would step it up to 45, and at 40, 24% surgeons feel that their volumes might be adversely affected. But all weight is not the same. We are looking at somebody who has an android or a central kind of obesity versus gynoid, versus that is a peripheral kind of obesity. And fortunately for us, most of the patients in India are predisposed to an android kind of obesity. I say fortunately because you et al. In the year 2018 said that it is not the BMI per se, but a periarticular soft tissue envelope that dictates the wound complications. Similar study but by Armstrong et al. In the year 2019, where he studied the inferior knee circumference, the ankle circumference, and the depth of incision, and found out that they are better predictors of surgical difficulty than BMI isolated. But what if the patient is more than 40? You tell them to lose weight, right? But are these weight loss requests successful? Reeves et al. Sent 280 patients to a weight management clinic only to find out that only 23% turned up, and out of those, only 20% could manage to lose weight. But what are the modes of weight loss? That depends on how much BMI you want to lose. If you want to lose around 3 to 5 units of BMI, we go for non-operative methods like diet and exercise. Recently studied peptide 1 agonists like semaglutide are coming up with weight loss about 15%. But the best possible alternative for these patients, if you want to lose around 10 to 14% BMI, is the sleeve gastrectomy, that is the bariatric surgery. Bariatric surgery in arthroplasty, what comes first? Now, often people think that you offer them a total knee arthroplasty, which will cause them to increase mobility, and then they will lose weight by either non-surgical or bariatric surgery. But this is not true. This has been proved time and again that despite increased mobility, patients maintain or gain weight post-operatively. So Werner et al. In the year 2015 said that you should offer a bariatric surgery to these patients prior to a total knee arthroplasty because it causes less post-operative complications. Similar study was done by Kulkarni et al. In the year 2011, where he found out the wound infection rate was lower in patients who were offered by bariatric first. But Yen et al. In 2022 did a meta-analysis, and he said that bariatric surgery first does in fact cause post-operative blood transfusion and perioperative blood transfusion. So the consensus is still not there as far as this question is answered. As far as tibial stem extensions go, these are 5 studies, latest ones, out of which the ones highlighted in orange would definitely say that stems are important as far as BMI goes above 30. This is a recent meta-analysis in the year 2024 that said that stem tibial implants may lower the risk of aseptic revision when compared to the non-stemmed ones. In summary, morbidly obese patients with BMI more than 40 have complication rates that outweigh the functional benefits. They should be counseled for risks and offered BMI after weight reduction, offered TK after weight reduction. BMI itself has limitations, but is right now perhaps the most useful and widely used classification. Infection, aseptic loosening, revision rates are definitely higher. Now let us look at the pre-optimization, what that looks like. You should be looking at the body habitus instead of BMI. You should be looking at the comorbidity. You should be looking at malnutrition, because albumin is a predictor of operative mortality. And you should offer them an individualized weight loss plan with a multidisciplinary team. You need more people in the OR during shifting. Vitamin E prophylaxis is still the gold standard aspirin 75 and not your oral anticoagulants. And you should titrate the recommended dose of prophylactic antibiotics according to the weight. Intravenous tranexamic acid and intraarticular has been proven useful, so has closed suction drains, and negative pressure dressings definitely help in wound healing as far as study goes. Closure should be with bidelection running multiple layers, and additional layers should be put in the subcutaneous fat. This is the 2022 study. And the choice of implant, as we discussed, should be stem tibia. Robotics has been proven useful as far as alignment is concerned in these patients, and rehabilitation should be with gadgets like Hoyer's lift to help them get up and anti-gravity treadmills. I want to end by saying that obesity is definitely bad news, but as Bill Gates said, you embrace the bad news to learn where you need the most improvement. And we have gotten from 6.7 complication rate 20 years ago to right now 4.6, and we are improving from here on. Thank you. These are my references.
Thank you, Abhishek. You finished on time. I'll invite the judges, Dr. D.D. Shah, first to ask questions.
In fact, I have visualized that those who undergo bariatric surgery may not need TKR. Has there been any study like that?
There have been studies showing the same, sir, that they definitely lose weight and they are symptomatically slightly better. But for somebody who has grade 3, grade 4 osteoarthritis, TKR is definitely the answer. They are not gonna get better. They will transiently feel better because their pain will go down, but they will need total knee replacement if they are grade 3 and grade 4 osteoarthritis.
We all accept that BMI more than 40 is no. But then with added suggestions by you, like improving the antibiotic and many other post-operative and intraoperative, like tranexamic acid and other things, till what BMI, according to your study, people have done surgeries?
So people have gone up to BMI 45 also, but I don't suggest we look at BMI as an isolated parameter. What we need to look at is what is the body habitus like. If he has a BMI of 42, but he is still centrally obese with thin legs, we can still offer to a TKR to a patient after a short-term diet course. So it depends on the fat distribution. It depends on the kind of comorbidities the patient has. It also depends on what kind of a lifestyle the patient is living. And then we can offer a TKR based on these parameters. So I suggest an individualized approach rather than looking at BMI in isolation.
For prophylaxis for VTE, what would you suggest in BMI between 40 to 45?
Sir, in fact, there is a study in 2022 done for the same. BMI for higher patients, we often give apixaban or rivaroxaban as a higher over anticoagulant. But what has been proven as the best is actually aspirin 75 mg for a period of 3 weeks post-operatively. That is of course
in combination with rivaroxaban or
yes, only isolated aspirin 75 mg. This is the latest.
Is that an
evidence?
evidence? Is that an evidence-based
Yes, sir.
statement, or it is just a
no, sir.
here?
There is a paper in the Journal of Arthroplasty in 20.
That is as effective.
Yes, sir. As effective.
And calf compression was given in such cases, those tweeters.
Sorry, sir?
Compression of the calf.
Isolated aspirin, or they were with pneumatic this cuffs?
No, sir. Isolated aspirin, but provided they are mobilized immediately after.
Enough from my side, please, Sir Darsar.
You have mentioned you have mentioned bariatric surgery preoperatively. Does any prehab sort of, is there evidence that you should force them to have ensure that you have a preoperative prehab sort of thing, exercises. Suppose you are somewhere between 35 and 40, so you can still do it. Does the prehab change any?
So between 35 and 40, I wouldn't ask the patient to go for a bariatric surgery. But yes, prehab has been, in fact, quadriceps and hamstring strengthening exercises have been proven to get them out of bed very fast and make
Yeah.
their rehab easier. But for a TKR outcome per se, it doesn't affect much. Weight loss is what they are looking at.
Okay. And although you have mentioned certain technical considerations like vacuum and this, are there any intraoperative technical consideration that alignment? Yeah, you have said rod, but you should always use a PS. You should not use a CR in such cases, or you should use major resection.
I did not come across any such studies, sir, but the only
Does
recommendation.
the technique differ in such cases?
No, the technique would stay the same. Some people do use a subvastus approach. They say that flipping of the patella is easier with that approach, but there are surgeries showing that both the approaches, a medial palipatellar and a subvastus, both have equal outcomes, and there is no change as far as if the surgeon is comfortable, he can do whichever approach he chooses.
And even surface metallurgy considerations like you should use oxenium, you should use this. Is
There are
there
no
any?
such recommendations, sir.
Okay. That's all I think. Ashish.
Yeah, Abhishek, good presentation. What I would like to know is, you mentioned that the complications are definitely higher. So, can we predict on which particular day? Long-term complications, yes, there are certain pointers, but is there any role of these pro-inflammatory markers that we can do in a particular patient preoperatively and see post if that helps us predict post-operative complications? I know that we cannot lose. The patient cannot lose weight in all the situations. But let's say we got a obese patient, I can do certain serological markers, and those will help me predict whether on day 3 or day 5 this patient probably is at a higher risk of developing an MI or a wound leakage or a wound dehiscence. Are there any such studies?
Sir, the only pre-operative investigation that I came across in these patient is what is suggested is a dobutamine stress echo to look at post-operative MI, but no other studies looking at embolism or any such if revision rates have been increased or decreased. No such study showing that.
Okay, then so obviously the average length of stay will be more in these particular set of patients. So do they these higher volume centers wherever you have sought these papers from, are they following a separate protocol for these patients post-operatively?
Sir, actually, they tried using the ERAS pathway for these patients, but they found out that it is not as beneficial for the obese patients because a lot of times they have to look at the complications and they have to look at the patient metabolically before sending them home. So that sort of a pathway is still not devised. In fact, a lot of people right now have been looking at getting a metabolic physician, getting the anesthetist and a multidisciplinary team together, but I didn't come across any pathway as such that helps these patients.
Right, and the advent of these robotics and navigation, which is coming in a very sort of a mainstream way, are our results getting better with these gadgets?
Sir, recently there is a paper in 2023 in the Journal of Arthroplasty itself that shows that definitely technical errors and implant malpositioning is getting better because of robotics. Because there is some sort of surgical difficulty when we approach these patients. But as far as the long-term outcomes are concerned, they are still the same.
Yeah, nice presentation. I just want to ask few questions. Any role of tranexamic acid, is it different from the obese patient and non-obese patient doses, or it is same?
So the dosage would be 2 grams instead of the normal 1 gram that we probably use in total knee arthroplasty patients. But nothing.
Dosage will be predominantly bolus, or it will be infusion.
Sir, they have suggested to give both intravenous and intraarticular for these patients. So you give a bolus dose and you also then give an intraarticular dose when you do the surgery.
Because 2 grams is quite high, because normally trauma-induced coagulopathy also we give roughly 1. So
Yes,
that
sir.
also.
But
And any
this is
paper,
looking at the weight into account, sir.
absolutely right. Any role of coagulopathy induced in the obesity, post arthroplasty?
Sir, obviously there is more risk of venous thromboembolism. Multiple studies proving that, but anticoagulation with aspirin 75 has proven to be similar as far as the non-obese patients are concerned. So there is no discrepancy as far as you use the right kind of anticoagulants and you mobilize them on day 2 or day 3.
And little out of syllabus, like any instructions, especially instruction anesthetics has been given to the surgeon, a coordination of anesthetics and surgeon for this obesity is more than 120, 130s.
Sir, apart from additional tourniquet time that the surgeon might require, nothing else that I can think of. Obviously, it involves a lot of things like changing the table itself sometimes, additional bracing, and you need to mobilize the fat. And all these things are taken into consideration. And there is quite a possibility of getting these patients for GA because spinal anesthesia
Yeah.
might not work every time.
Okay, that's it from my side.
Okay, thanks, Abhishek.
One
I
more,
would
one more
suggest-
last question on a lighter note.
Yeah, sure.
Is there any, I mean, have you read any papers, or is there any evidence to back that surgeons should be paid more to operate on obese patients?
There have been studies showing that you need to give additional incentive to surgeons so that they don't
it
deny
published?
the access to care, is what they call. Because right now what is happening is, especially in America, if a BMI of 42 with a peripheral obesity comes in, the patient is being refused surgery, and then the vicious cycle goes on where the patient is not able to lose weight and his osteoarthritis getting worse. So there is a paper, in fact, it was in 2021, if I'm not mistaken, the same American Society of Hip and Knee Surgery, which said that you need to incentivize these surgeries so that you have more people taking in these risks and these complications.
Okay.
Because sometimes the patient is stuck in a vicious cycle and there is no end to it.
Okay, thanks, Abhishek.
Thank you, sir.
Ask the judges to give marks to Abhishek and invite our next speaker, Dr. Yash Ved. Yes, you can start sharing your presentation.
Yes, sir.
Okay, go full screen. Yeah, we can see your presentation. We can hear you. You can start.
Good evening. I am Dr. Yash, and I'm going to be talking about the management of early stage of hip AVN. Hip AVN is a very common problem in clinical practice, which has its roots in intraosseous venous hypertension and ischemia, eventually progressing through to collapse and joint dysfunction. How the treatment plan interrupts this cascade is either by reducing the pressure inside the femur head, by repopulation of cell lineages, or by providing additional mechanical support to the already weakened bone. The eventual goal is to delay the collapse and preserve the joint space. AVN of the hip has been multiply classified, and the latest classification is the ARCO classification or the staging, which has been modified recently in 2019. This is a narrative review of PubMed indexed articles of the last 10 years. Several treatment options exist to treat AVN of the hip, and for the early AVN hip, among the joint preserving options, the most common and the frequently researched option is that of core decompression, which has been modified several times over the course of the past 60 years that it has been in existence. Among the first modifications is the modification and conversion of use of a large trephine to a small 3.5 drill bit, and this change has significantly reduced the time to collapse. Increased the time to collapse and reduced the collapse rate at 3 years, and has also reduced the rates of subtrochanteric femur fractures as a complication of the surgery. But is core decompression alone adequate? So this meta-analysis of 49 studies in 2021 has shown that it can only provide short-term clinical improvement in terms of pain when it is used in isolation. And out of the 2,500 hips which they had included, 38% had to undergo a total hip replacement at a mean time of a little over two years post the core decompression surgery. And this hence has put forth the need for augmenting the outcomes of core decompression, which can be done by using other ancillary methods which are used as an add-on to core decompression surgery. And this network meta-analysis has attempted to grade the efficacy of each of these augmentations. So they have concluded that the marrow stem cell augmentation is the best amongst all of the augmented core decompression surgeries. But however, all the augmented core decompression techniques are able to do better than core decompression alone. Philip Hernigu was the person who had originally suggested the use of mesenchymal stem cells to augment core decompression. And he has presented a 30-year follow-up of 250 hips, which he had operated upon in the late 1980s. And he has done augmented core decompression on one side and normal core decompression on the other side. And he has suggested that in the augmented core decompression group, the failure rates have reduced to 1/3 as compared to the core decompression group alone. Another meta-analysis in 2018 has suggested that when core decompression is used in an augmented way with other biological therapies, there is an average survival, a pooled survival rate of 80% at the end of 10 years, which was obtained in over 2,600 hips, which they included in their meta-analysis. The dosing of the cells is a frequent round of debate, and this meta-analysis of 23 studies has come to a conclusion or has recommended that a 20 ml injection volume is to be used with a bone marrow mononuclear cell count of 10⁹ at least to get good clinical outcomes. Should it also be done on the asymptomatic side, which may be detected on a PBH MRI for one symptomatic side? Both of these articles have recommended that if the Japanese Investigation Committee classification, the JIC classification, is used, which grades the necrotic region into type A, B, and C. If the necrotic region extends far laterally, that is the type C hips, then even if the patient is asymptomatic, a core decompression should be done on that side because the collapse rates are very high to the tune of 36 to 85% at the end of 5 years if that patient is just observed. The rehab protocol, as suggested by the Hospital for Special Surgery, has suggested that high impact activities be avoided for 12 weeks. But at the same time, they have emphasized the importance of early range of motion and weight bearing as tolerated with an assistive device, with gradual progression of the physiotherapy, eventually reaching the assessment for return to sport assessment after the end of 3 months. Some technical guidelines. This paper in 2024, this year, has attempted to adopt a holistic approach to treat the intra-articular pain generators, which may be the femoroacetabular impingement and labral tears, which are present in nearly 64% of the patients of AVN of the hip. Following this problem being addressed, they used expandable reamers to make a large core in the head while leaving behind a narrow footprint in the neck, followed by bone marrow aspirate concentrate injection and impaction with cancellous bone grafting. Medical management, yes, there have been some single center studies which have given some benefit, but overall the results have been inconsistent and there is no consensus as to the use of medical management in current time. For the point of decision making, ARCO subclassification, which has classified the hips similar to the GIC classification into type 1, 2, and 3, has suggested that if the necrotic area extends lateral to the lateral acetabular rim, there is a very high chance of collapse and conversion to THR, even if augmented core decompression is used, and hence caution should be exercised. Some MRI predictors which can predict the failure of augmented core decompression procedure are the presence of edema in the neck or the acetabulum, the presence of subchondral fractures, or effusion and synovitis in the joint, and a large lesion which is extending into the lateral weight-bearing lesion. A paper in 2023 used a regression analysis on 1537 hips with a greater than 2-year follow-up, and on the basis of a hazard ratio, figured out 7 variables and developed a scoring system which could numerically give us a score which could help us to quantitate the risk of failure of augmented core decompression in any given patient. And for instance, a score of greater than 20.5 in any patient would mean that the augmented core decompression is going to fail 100% at the end of 2 years in that patient. The S3 guidelines have suggested that there is a strong recommendation for the use of core decompression and arthroplasty. However, they've only given a moderate level consensus for the use of bisphosphonates. For the core decompression, they suggested that only a limited necrotic area with a lesser than 30% femur head volume, along with a lesser than 200-degree cumulative Cabool's angle, should go ahead with a core decompression in the pre-collapse stage. current concept review by JBJS has suggested the recommendation of grade A for all modalities of core decompression as well as total hip arthroplasty for the respective patients. But all non-operative managements have been given an inconclusive grading, including the use of bisphosphonates. The JOA guidelines given in 2021, they have analyzed over 300 studies and have suggested that both augmented core decompression as well as total hip arthroplasty is given a grade 2 recommendation. However, all the offloading and non-operative management, along with the plain core decompression, has been given a grade 5, that is the lowest level of recommendation. They have recommended that the biophysical methods can only reduce the pain symptomatically, but there is no evidence of collapse prevention. Bisphosphonates lack high-level evidence and hence their use is not recommended clinically. Augmented core decompression should be used in meticulously selected patient cohorts. Total hip arthroplasty can be used. It provides excellent functional outcomes. However, as of now, we have a maximum of 10 to 20 year follow-up data of the current latest implants, and longer term data is lacking. As of now, there is an 85% survival rate at 10 years across studies, and they have recommended that joint preserving surgery should be considered in the young patients if they fulfill the criteria for these surgeries. To conclude, yes, THR gives excellent functional outcomes, but because of the risk of multiple revisions, augmented core decompression should be considered in relevant patients. Thank you.
Thank you, Yash. You finished on time. I'll invite Dr. Didi Shah for questions.
Thank you very much for making me the first questioner. It was a good presentation and I compliment you for that. My question is, are the avians because of COVID, all of them are same or they are different, and are there different approaches in your study?
Sorry, sir, could you repeat all
the avians, including those which are because of COVID and COVID treatment, same or they differ? And in your study, have you encountered that?
Yes, sir. There have been studies. The main reason for the COVID, why AVN happens is primarily because steroids have been used rampantly in COVID for the treatment of the worst lung getting bad. So this technically, in one way, it is also a steroid-induced osteonecrosis of the femur head. But apart from that, AVN is also a part of the long COVID syndrome, which is known. But the way it behaves is similar to steroid-induced AVN, and the treatment modalities also remain the same, along with the functional outcomes, sir.
Did you encounter any stem cell kind of treatment in such situations?
Yes, sir. Stem cell, basically the injection of mesenchymal, the bone marrow aspirate is one of the modalities of stem cell treatment. However, the concentration of stem cells is not as much in them. So recently there have been some studies which have concentrated or cultured the aspirated bone marrow pre-operatively, and then the bone marrow aspirate which has been enriched with stem cells is then injected into the necrotic area. So bone marrow is the most common source of stem cells which have been used. Other stem cells such as the adipose derived mesenchymal stem cells are also in use, but large studies are not available for the use.
In conservative treatment, people have deviated from bisphosphonates to denosumab. Have you come across these studies?
Yes, sir. There were studies on the use of denosumab as well as teriparatide in the use of for their use in the AVN of the hip. Denosumab, I came across two surgeries. Both of them had about 100 patients. They had compared it against alendronate. Both the studies have shown that there is an advantage over alendronate. One study, there was a 54% collapse rate at the end of 2 years with alendronate and a 45% collapse rate with denosumab. And the p-value of this study was 0.02. So there was a significant difference as compared to alendronate, but we do not have, and even teriparatide, the significance level, it was significantly better than alendronate in its use. However, we do not have large-scale trials to warrant their cost and the long duration of treatment as a standard of care in treatment of AVN of the hip, sir.
That's good. My question now is, we have been doing core decompression, but then are there any papers where along with core decompression, there were fibular bone grafts introduced in the areas which were most affected?
Yes, sir. So earlier, when we used to do a large core decompression, which was the 8 to 10 trephine, we could put in an entire fibula inside. It could be vascularized or it could be non-vascularized. As far as the vascularized fibula graft is considered, in the German guidelines, the S3 guidelines, they have suggested that vascularized, and also in the Japanese guidelines, they have suggested that vascularized fibula has good outcomes, but just when we look at the functional aspect of the patient. However, the surgical time, morbidity, and the blood loss, and the need for more surgeons to be doing the same surgery, all of these factors have limited the use of vascularized fibula to be used in, or any other vascularized graft to be used in the treatment of AVN of the hip. As far as fibula is concerned, it is a structural graft. So yes, it is one of the techniques by which augmented core decompression has been augmented, because it is able to, as shown in the cascade, one of the elements of the cascade was a weak bone. So that fibula is able to directly attack that part of it, that it provides some amount of structural strength to the collapsed part of the head. And it does provide benefit over standard core decompression. But when all the augmented procedures are compared, the mesenchymal stem cell injection along with cancellous bone graft gives the maximum benefit. Also, when cancellous and cortical bone grafts are compared, because the metaphysis is naturally a cancellous bone and resistant to stress in its own way, putting in a cortical bone in the region of a cancellous bone, the cancellous bone did better than the cortical fibula grafts.
Are there any markers which can say that in grade 3, conservative will work or surgery should be imposed?
Sir, grade 3, there were very high failure rates of conservative management, but still, because all the rates are an average, so it is not recommended. But if the patient is very young, a trial can be given to get whatever benefit of time that we can get before the patient would have to go in for a total hip arthroplasty. Pain relief is immediate with core decompression, but how long it will last in a grade 3 AVN, it is difficult to say if it is going to last for a long time. Short-term benefit will definitely be obtained.
Thank
Since
you.
the benefit is...
May I request Dr. Dhar sir to take over?
Yeah, so question something similar Dr. Shah asked, like, fibula, maybe I have missed any of one of your papers. Is there any comparative study that with fibula and without fibula, only core decompression, or with biologics, the success rate has changed? Because earlier,
Yes, sir.
I'm sure my generation surgeons, all of us have done fibula stud grafting, but we gave it up because we thought later THR would be tough and difficult.
Yes, sir.
Are there any studies which have compared these?
Yes, sir. So the network meta-analysis,
Recent
which I
ones at
showed,
least?
yes, sir. The network meta-analysis which I had shown, which was done in, I think, 2018. So it had compared 5 modalities of augmented core decompression, in which fibula was one of them. So even though mesenchymal stem cell injection is better along with cancellous bone graft, it is better than, it performs better functionally than a fibula graft. But a fibula graft is better than core decompression done in isolation. So it augments the strength and hence the collapse may be delayed. However, because it does not have the osteogenic potential of cancellous bone along with mesenchymal stem cell, it is only able to address one of the elements of the cascade, whereas the mesenchymal stem cell along with cancellous bone is able to address multiple aspects of the same cascade, and hence it is probably the reason why it gives better outcomes than a fibula alone. And also the
Regarding
fact
this,
that the total
yeah,
hip replacement would become more difficult, as you mentioned rightly, sir.
regarding this non-operative medical treatment, I'm sure most of us, almost every one of us prescribes those medicines, but we probably give it for the fact that there is some pain relief, particularly as Dr. Shah said, post-COVID, we are seeing a flurry of patients with the AVN. So is there any study that they cause better pain relief or they improve the time till THR? A study, something like that, which you could find from the literature?
Yes, sir.
That
So
you
there is
could delay the time between those which have been given alendronate or all those therapies. Some people give alendronic. They say now we give teriparatide, everything, all those concoctions we give. So are there any standardized studies where they could find out that at least they cause pain relief, functionally they improved, or the longevity to THR, time to THR has changed? Because
sir.
I personally, I give it just for the sake of delaying 1 to improve the shock of the diagnosis, and second, to probably their younger age groups. So are there any studies which you could?
Sir, for alendronate isolated, so Dr. Sanjay Agarwal, sir, from Hinduja Hospital, he had a study earlier when alendronate 10 mg was available. At that time, he had a 10-year follow-up study in which and then when alendronate was discontinued, the 10 mg formulation, he went ahead with alendronate 35 with zoledronic acid yearly injections. So the whole purpose of doing this zoledronic acid drill was that alendronate by itself, when used in 10 mg OD dose, it had a delay in pain relief. As in the onset of pain relief was delayed, which still caused some amount of distress to the patient, which may also be affecting the compliance of the patient. So from that aspect, alendronate only therapy may not be immediately effective in pain relief. Apart from that, from what I could find, Dr. Sanjay Agarwal's sir study was the only large-scale study. Even though it was a single-center study, he had included nearly 900 patients in his study. That was the only study which found a significant benefit. But in his study, the results are very good. But in all the other meta-analysis which I could find, or all the other smaller studies, they have been discordant, and the same amount of benefit could not be obtained as Dr. Sanjay Agarwal sir has obtained. And that is also one of the reasons why none of the three guidelines which I could find give any sort of recommendation for bisphosphonates or any other medical management, be it denosumab or be it teriparatide. Denosumab and teriparatide are relatively more recent treatment therapies for osteonecrosis, and hence large scale studies are not yet available. Most of the studies are single center studies on about 80 to 100 patients.
Could you get hold of any post-COVID study? Because the pattern of AVN in post-COVID patients is very different. It means you have a diffuse metaphyseal edema, which suddenly vanishes once you start alendronate and other medicines. While in conventional, what Dr. Agarwal has studied, they were localized grade 1, grade 2 AVN. So have you got hold of any post-COVID studies?
Sir, there were studies which were published after COVID went, sir, but none of them specified that they included patients only after the 2021-22, sir. Because that would be just having maybe 1-2 year follow-up of patients. So I have not found any such study which has taken patients specifically from after the COVID era.
Yeah, thank you. Excellent. Dr. Ashish.
Thanks, Ved. So just take me back to the scoring system that you mentioned for predicting the failure. Can you just summarize it again for me?
Yes, I'll just should I share the slide again, sir?
No, I mean, you can just narrate it out. Which are the red flags in your in that particular study, and where was this group from who published that study?
Sir,
you can just tell it to me. That's not a problem. Don't share the screen. Would rather see you speak.
Yes, sir. Sir, the group was, I think, from China, sir, and they had analyzed retrospectively patients whom they had already treated. And from then, regression analysis was done, which by the means of a hazard ratio, as in they had compared around 20 variables and took out the hazard ratio for each. So what they did was these 1500 hips, they considered them and they divided them into two groups, ones which failed and ones which didn't, and comparing all these variables for both of them in retrospect, they then took out this scoring system in which they've included 4 patient specific factors, which is basically their age, gender, occupation, and hemoglobin, and 3 disease related factors, which is the duration of disease in months, the etiology, and the combined necrosis angle, which is the Kabul's angle. So on the basis of the hazard ratio, they allocated different scores giving different weightage to each variable. And for instance, in etiology, they found that idiopathic and steroid-induced AVNs failed more on co-decompression than did alcohol-induced AVN. So in those patients, they gave them a score of 2 each, whereas alcohol-induced AVN was given a score 0. So when all of these 7 factors scoring is totaled, when the scoring is total out of 28, what score the patient falls in, we can estimate a risk of the treatment failure, which will also probably be important to the patient for him to know. We can tell him that there is a 40% chance that at the end of 2 years you will have a failure of treatment, and it is also important for us to make a decision whether to provide that treatment to that patient in the first place.
Okay. Now you can stop sharing the screen. Not a problem.
Yes.
So this is would you like to? I mean, which are the studies which are multicentric in your review of literature?
Sir, most of my studies are meta-analysis. So they have included somewhere around 35 to 45 studies. So all the meta-analysis are comprehensive. One of the study was done, which was done by Dr. Philippe Hernigu, the 30-year follow-up. So that is a single center study. This scoring system was also a single center study, the one which I just showed, sir.
Not a problem. Yeah. So basically, what is the worst failure rate in any of the good meta-analysis that you have seen with a augmented core decompression, whatever kind of augmentation they have done? What is the worst failure rate?
Sir, the worst failure rate at 5 years was somewhere around 35%, sir, in the worst meta-analysis, sir.
35.
For augmented core decompression, but not
What's the best
plain
survival rate?
So best survival rate was obtained at 5 years of 90%, sir.
Of 90%. So, I mean,
Yes,
I
sir.
need to understand that, in your slide itself, you have said that the THR is about 85% at about 20 years. Is that what you said? The modern.
At 10 years, sir. 10 years,
10
yes.
years. So, to me, it looks like THR is still a better option than an augmented core decompression.
Yes, sir. So that is what in my conclusion slide I wanted to point out, that even though THR gives excellent functional outcomes and the survivorship of THR and core decompression might be the same or even maybe slightly variable, but if core decompression fails, we still have an option of a THR. But if a THR fails, it is going to be another revision, and the functional effect of a revision surgery is not going to be as good as a core decompression or as a primary THR. And suppose the patient is maybe 25, 30 years of age, which the average age of AVN in India is 34 years. So average would be.
This 34 years is coming from where?
Sir, sorry, sir.
This 34 years ka value, where is this coming from? Is it coming from literature or is it?
Yes, sir. It was an article in IGO in which they had an Indian population roundup. So 34.
I don't doubt the fact. So what I wanted to ask is, why are they still recommending that augmented core decompression could be a better option to be offered to the patient as compared to a conservative, a medical line of management versus this thing? Because if you see, the risk of failure of all these three is more or less the same, isn't it?
So three is which three, sir? Core decompression, THR,
core decompression, medical management, and total hip replacement.
No, sir. Medical management is not recommended by any of the recommendations because they have a very high collapse and conversion to THR rate. For augmented core decompression and THR, even though they last the same, but it is always the question of having a second plan. So the second plan after a core decompression is a primary THR. So that is the whole difference, that we want to avoid the risk of multiple revisions that the patient may require versus a short term, maybe a THR if it lasts. What if he's among the 15% who are not lasting at 10 years? So that will lead to him having maybe 2 or 3 revisions in his lifetime.
Right. So the bias in the publications that you have selected is basically a lot of Japanese articles and the Chinese articles. Is that right?
Sir, there were 3 articles. All of them were not Japanese or Chinese. The ones published in International Orthopaedics. The 2023 article was Chinese, but the other 2 guidelines, the one is the Japanese guideline and the other is a German guideline.
They're published where?
Sir, mostly in International Orthopaedics, and the Chinese one was published in Musculoskeletal Disorders,
okay.
And one trend was published in the Journal of Arthroplasty, sir.
Okay. So I was more interested in looking at the JBJ's American or the British JBJ's or the Journal of Arthroplasty. The European or the American literature, which we in India tend to generally follow.
Yes, sir. There was a JBJ's current review recommendation paper as well, sir.
Right.
Yeah, in 2020.
Okay. Yeah, yes, nice presentation. Roughly what Ashish was also trying to tell, that could be a multi-levels, multi-centric study will really more helpful rather than like a singles institute study. So that was one message, I think so. And just a vague question, like a role of arthroscopy, like in grade 2, grade 3, as you said, labral stain, any other role? And have you yourself experienced that and done it?
Sir, I have not done hip arthroscopy along with the core decompression, sir. But the main 2 reasons why arthroscopy is suggested is, one is to evaluate and assess the intra-articular pathologies, and the second one is to assess the contour of the femoral head, because always arthroscopic evaluation is always more informative than an MRI evaluation. And third would be to assess whether the articular surface has been breached by either a drill bit or the guide wire of the core decompression. So these are the three uses wherein the arthroscopic evaluation of the hip may come into use.
Yes, any articles suggesting complications like fractures post decompressions?
Yes, sir. So the rate of fractures has reduced because the 10 mm trephine has now been reduced, and we are now doing only small core decompression, such as the expandable reamer, which is a 5 mm, and the entry is suggested over the level of the lesser trochanter. So yes, it is
How
one
much it
of
has
the.
gone down? Just interrupting. How much has gone down from last decade to this decade? Any studies suggesting something like that?
I am not aware of the incidence
Okay.
difference, sir, but earlier on there was a 13% incidence in when the code trephine was used. But how much it has, there is a significant difference, but I do not recall the percentage wise, sir.
Okay, no problem. Good.
So, I mean, this expandable reamer that you mentioned, is it available in the city of Bombay?
I am not aware, sir.
Right.
It is by Arthrex. It is Arthrex reamer, but I am not aware, sir.
Okay. So coming back to presentations and review of literature. So whenever you have less strong evidences, people generally tend to get any consensus statement. So avascular necrosis, does it have any consensus statement by a study group or something like that? Have they come up with any consensus statement? Do you know what a consensus statement is?
Yes, sir. So the in my decision making slides, so the consensus statement was the S3 guidelines are basically a consensus on the based on Delphi methods. So they had about, I think, 50 surgeons on 50 surgeons in their panel, whom it was a questionnaire based Delphi method analysis, and based on the Delphi method analysis, so it was a global analysis of 50 surgeons from, I think, 8 countries, and it was a consensus analysis of all these 50 surgeons. The
But did they
S3
meet
guidelines.
physically, or was it on a electronic?
No, sir. Delphi method electronic database. They had 3 physical meetings, but
Okay.
apart from that, the correspondence was online, sir.
Great, great, very good. They should meet physically. For you
Yes,
to,
sir.
yeah, for you to take the consensus seriously, the consensus group has to meet physically.
Okay, thank you. Thank you, Yash.
Thank you, sir.
Judges can give their marks while Taarini is here. She can share the presentation. Go ahead, Taarini. You can share your presentation. Okay, we can see your presentation.
So is the presentation visible?
Yeah, it is visible, but we can all
Sorry?
see your side panel with comments.
Oh, okay.
I mean, that's the presenter's review.
Not sure how to.
She's presenting on iPad.
Yeah.
Okay, sir.
Go ahead. Start the presentation. Let's see. Okay. On the right side, just cross the the text box.
So just a second, just give me a second.
Yeah. Figure it out.
Ashok, there is a echo. Maybe she has
There
got
is
the two device.
One from two gadget.
Yeah, your Didisha is right. She must have done from 2 gadgets, and that is the reason it is echoing.
Who has done for 2 gadgets?
Well, keep muted everyone else.
So I think Taarini must be having 2 gadgets nearby.
Okay.
Yeah, I'll just
Mute one of them.
Okay.
Then we'll keep on. Okay.
Just 1 minute. Sorry, sir.
No, it's all right.
Okay. I will just remove those notes.
Let the notes be there.
That's fine, sir. Okay, is it okay now, sir?
Yeah, we can see.
Okay.
Go ahead.
Good evening, respected judges, colleagues, and viewers. My topic today is to fuse or not to fuse in degenerative lumbar spondylolisthesis. So what is the objective of this literature review? It is to assess the current available evidence comparing outcomes of fusion versus no fusion. Why must we do that? Many may presume that slippage and dynamic instability at the level of spondylolisthesis are better treated with fusion. But let's see what the evidence has to say. So I have used the following databases to search for studies published since 1991 focusing on this topic. In brief, degenerative spondylolisthesis is a condition in which a vertebra has slipped forward in relation to the caudal one. The patients are usually older than 60 years of age and they typically have leg and back pain. They also have restricted function due to lumbar canal stenosis, and these are brought upon by degenerative changes. Hence, the goal of treating this condition is mainly decompression, and the techniques are many. So let's see. Originally in the 1970s to 80s, fusion after laminectomy was considered unnecessary. But from the 1990 onwards, the trend changed and decompression augmented with fusion was considered gold standard. This shifting trend towards fusion was well documented in a retrospective review by Kepler et al. They also pointed out that the associated costs of instrumented fusion surgery for degenerative spondylolisthesis in the year 2011 was $13 billion. So you must be thinking, what caused this change? Well, it was because of this landmark paper published in 1991 by Herkowitz and Kurz. They compared laminectomy alone with uninstrumented fusion in 50 patients and found that at a 3-year follow-up, arthrodesis provided superior relief for both leg and back pain. But the limitations of these studies were the lack of randomization and that they only focused on the clinical outcome. Now, in another prominent study in 1997 by Fishgren, in which Herkowitz and Kurz were authors as well, they also looked at the clinical and the radiological outcomes now. Here, 68 patients were randomly assigned into 2 treatment groups, that is laminectomy with uninstrumented fusion and laminectomy with instrumented fusion. The radiographic results heavily favored the instrumented fusion group, but the clinical outcomes were not superior. Hence, concluding that the use of pedicle screws may lead to higher fusion rate, but not very superior clinical outcomes at a 2-year follow-up. And please remember that I said 2-year follow-up here, because in this study, the third most influential study of that time by Kornblum et al., where Herkowitz and Fishgren were authors as well, they took the patient from the 2 previous studies that we just discussed. And they specifically followed the arm of patients that underwent laminectomy with uninstrumented fusion. They divided these patients into 2 groups, the one that had successful fusion and the one who developed pseudoarthrosis. Crucially, they looked at the long-term influence of pseudoarthrosis on clinical outcomes. So when we're talking long-term, we're talking 7 years here. So they saw that achieving a solid fusion led to significantly better long-term clinical outcomes compared to pseudoarthrosis. So by the end of 2004, we are left with 3 great studies that painted this picture. Now, the problem is till 2016, there was no high-end randomized control trial. But then came this study by Frosch et al. That compared laminectomy alone with laminectomy plus fusion. And this was a study of 247 patients, but only 133 had degenerative listhesis in this group. So the study details, the study does not detail the type of surgery. They just mention it as decompression versus fusion. But they found that there was no significant difference between the 2 groups and the mean score of ODI at the end of 2 years. And they concluded that decompression with fusion did not result in superior clinical outcomes. Now, again, like they say that the show must go on. Another equally strong study was published in the same year, 2016, and they had contradicting results. Here, the study was by Gogawala et al., known as the SLIP trial, compared laminectomy versus pedicle screw instrumentation. The researchers excluded patients with unstable spines, ensuring that the study group, they did not have any confounding factors. And they also aim to evaluate that if we do decompression, does it destabilize the spine? So on the 4-year follow-up, they concluded that the fusion was associated with a slightly greater but clinically meaningful improvement in physically health-related quality of life. There was reoperation rates which was higher in decompression when compared to fusion. So again, we are at a clinical equipoise. And now I need a deal breaker of sorts so we can conclude this literature review. And luckily, it does exist. In fact, this is the latest and the most promising multicentric randomized open label study known as the Nordsten trial. This was done by Ostwald et al. It was conducted in Norway to compare the effectiveness of decompression surgery alone versus decompression surgery instrumented fusion for treating lumbar canal stenosis with Degenerative. The trial included patients aged 18 to 80 and the following inclusion and exclusion criteria. So patients were followed up to 2 years, and it is interesting to note that among the included patients, dynamic instability was among 20% with a slip angle of more than 20 degrees in 36% of patients. Also, they made it mandatory to use the microscope here. So the trial demonstrated that decompression alone was non-inferior to decompression with fusion regarding the primary outcome. They also said that fusion may not provide a significant advantage in terms of clinical outcomes for many patients in this population, and that the potential risk for higher reoperation rates after decompression alone warrants consideration when discussing treatment options with patients. So the study also highlights that decision to do a reoperation is influenced by many various factors like patient symptoms, surgeon's judgment, as well as the healthcare system factors. Therefore, the reoperation rates observed in this trial may not solely be attributable to the initial surgical approach. This is a small summary of the 3 last papers that we just saw, and we can see that the finding of the Nordsten trial and the Fjord et al. Trial are quite similar, and both have high number of patients. So my take-home message here would be fusion may not be necessary for all patients with lumbar canal stenosis and degenerative spondylolisthesis. It may play a role in reducing the risk of reoperation in some cases, and the potential benefits of fusion must be carefully weighed against added complexity, risk, and cost associated with this procedure. These are my references. Thank you.
Thank you very much. I've finished on time. I'll invite Dr. D.D. Shah sir to start the question.
It has been very nice evening, and I think you are in Davos just now.
Yes.
Okay. Are this fusions done with instrumentation or without instrumentation, and did it make any difference?
So the largest trial, they have used instrumentation, and the type of instrumentation, that is the last paper, Nordsten trial, the type of instrumentation that they used was left to surgeons' discretion. So per se, I cannot say that what kind of instrumentation is better, but they have only used it as a source of fusion in patients.
To prove fusion, have they done CT scan at the end of 1 to 2 years? How did they conclude that there has been a complete arthrodesis and it is not fibrous union?
So, sir, most studies did not do CT. They did plain radiographs and saw for continuation of the solid bony fusion. And also radiographically, that is the only parameter that they focused on. But mostly they also looked more at clinical outcomes, because there have been many patients in which there was a slip progression with, even with fusion or uninstrumented fusion, but the patients were asymptomatic. So
this grade was reduced or it was fused in situ?
So it was fused in situ. There was no mention of any reduction screws or reduction maneuvers in the papers.
That's enough from my side. May I request Dhar sir to go ahead?
Thank you, Dr. Shah. Excellent, Dr. Taarini.
Thank you.
Just wanted to know, means have you studied this, like our conventional fusion, as Dr. Shah said, PLF and PLIF? Have you studied any? You have talked only of non-fusion, but earlier we used to do just posterior lateral grafting and then see. Has there been any difference as per the literature between just doing conventional rather than doing interbody fusion? Are there any good articles or good references?
Yes, sir. So in the Frischgren study, the second paper that I quoted, they compared uninstrumented PLF versus instrumented PLF with pedicle screw fixation, and the number of patients were around 66. In that group, in that study, pedicle screw fixation proved to have higher fusion rates, but the clinical outcomes were non-inferior, like they were not very great. So there one can argue that yes, when we do fusion with instruments, we get a more solid fusion than compared to just PLF. But clinically, it may not be very
In
superior.
grade 2 and 3, all of us agree that instrumented fusion or even reduction. But I'm talking of grade 1, grade 2, maybe borderline grade 2. So is there any benefit of doing instrumented or a complete PLIF or TLIF like thing?
So, sir, since I've chosen degenerative listhesis, all these studies only focus on grade 1, since it cannot be more than that. So, yes, like they said in the largest study, it does not really make a difference to instrument or to not to
See,
instrument.
earlier, when I was younger, we used to do just interbody intertransverse grafting, and we thought that there is a pseudoarthrosis developing there, so it makes it little more stable. Although there is some, so it provides both dynamicity, so less adjacent segment disease, but it also gives some element of fusion. So that is that. But then there were no real classic studies which actually read them. So did you find any old literature, young, fresh literature about this?
Yes, sir. The second study that I quoted in this presentation by Fishgren, they exactly compared the kind of patients that you just said, the one with posterior lateral fusion with just the intertransverse bone grafts in matchstick fashion versus the pedicle screw fixation for the same homogenic population. And they found that pedicle screw fixation was giving more solid fusion compared to the the bone graft just. But then the next study, this was just 2-year follow-up, but then in the next study they found that the just doing a PLF is also gives a higher risk of doing a reoperation surgery because there may be a slip at the same level, slip increase. So these are the two differences. But
So
as
any difference in the adjacent segment disease or anything?
yeah, there is also a reoperation rate for fusion. Exactly. So when we do argue that when we do decompression, there is a higher chance of reoperation, but it actually also exists. When with decompression, it is 12%, with fusion, it is 9%. It is from the Nordstrom trial. So adjacent, it is all most patients had the adjacent segment at a 4 or 7-year follow-up.
Okay. My last question is, since you're talking about degenerative, in geriatric patients, does it make a difference that which one you choose, that you should less is better, less harm is better? So I'm talking of real geriatric patients, 70s, 60s, where we have multi-level disease, yet we have identified one single level, which is the culprit level. So you do decompression. So will you get away with the non-fusion technique, or you would still do a fusion if it is grade 2 or at that level?
Yes, sir. So the most
So
patients.
does the literature give any clarity on older patients?
So all the patients that were included were mostly above the age of 60 to 80. And in these studies, we could see that the main symptoms because of these degenerative changes is claudication. Back pain has multiple factors. So when you take that into aspect, unless somebody is presenting with severe transitional back pain or back pain dominant symptom, it is very okay to do just decompression surgery in a patient with a stable degenerative spondylolisthesis with canal stenosis.
So I come to that question that is there any red flag in old patients that here is this patient who has only radicular pain, claudication pain, you may just get away with PLF or PLIF, whatever you PLF. But if there is a lot of backache and this, is there any literature sort of evidence based? I know everybody has his own opinion on this, but Could you get any evidence on that?
No,
That they
there
have
are no
found better results in backache, pure backache patients with
no, so
grade
there
1 or
are
grade 2?
no studies that purely focuses on back pain, like I said, because it has multiple factors, except for the one where I said in the Gogawala study, where they took patients specifically who did not have instability pain. They wanted to rule out these confounding factors, and then they also saw that here fusion did do better in these patients. But again, there is in geriatric patients, you always have to kind of weigh out the risks of doing the surgery, longer hospital stay, more bleeding, dural tears. So per se, decompression does weigh out a lot of other reasons.
Thank you. I think that's it. Ashish.
Hi, Taarini.
Yes.
Good presentation.
Thank you.
I wanted to know something more about the Nordstern trial. Okay, you mentioned that the inclusion criteria was 18 to 80. Is that correct? Did I hear
Yes, sir.
correctly?
Yes, sir.
But we're talking about degenerative spondylolisthesis, right? So, would you? I mean, as a non-spine surgeon or a general orthopedic surgeon, I fail to understand why would younger patients present to you or someone with a degenerative spondylolisthesis at a younger age?
So it is true. I also looked into the paper that why would they choose that age group? Maybe they wanted to just do increase the population that they're including the type, but
Okay. Then you mentioned about that difference in reoperation rates in non-fused and the fused segment. What was the predominant reason why the non-fused cohort was undergoing a reoperation?
the non-fusion cohort was undergoing reoperation because they developed an increased slip at the same level of listhesis.
Okay, that is within the first 2 years, right?
Yes, sir.
Okay, and what was the reason? So they were still classified as a degenerative spondylolisthesis, and it was not like intraoperatively they changed their findings, or let's say there was an extension of laminectomy or decompression, which led to an instability or so.
No, sir. So they all actually followed the same thing, laminectomy with a little medial facet resection. So no diagnosis was changed post-operatively.
Okay. Then amongst the instrumented cohort, what was the commonest cause for a reoperation within the first 2 to 3 years?
So the commonest cause was the patient developing a disc herniation or adjacent segment disease at the above level of the instrumentation.
So I'm not sure. I mean, I'm not a spine surgeon, but does it develop so soon, an adjacent level disease? I mean, it may.
Adjacent does take quite a few years, like 7 years. Trial mentioned it more, but disc herniation can develop.
Okay. Then are there any? I mean, this Gogawala study was an Indian study?
No, sir, it is from USA.
Okay. So are there any Indian studies to match your findings? I mean, are these results replicable in our subset of patients?
So as of now, I couldn't find a very big multicentric level 1 study for India.
Even if, I mean, let's say a consensus statement or multicenter, whatever, retrospective study in India?
No, so there was one paper by Dr. Arvind Kulkarni that described the different kinds of spondylolisthesis and their outcomes, but per se it was not just focused on degenerative spondylolisthesis, or to compare the kind of surgeries in that.
Right. This Nordstern trial, just remind me, you said it was a randomized controlled open trial, right?
Yes, a randomized multicentric open label non-inferiority trial.
It is not. So, and who assessed the outcomes? Was it the surgeons themselves? Were they blinded to, or was it the physiotherapist or someone else?
Yes, sir. The only limitation to this study was actually that only the person who analyzed the results, the statistician, was blinded. Otherwise, it was an open trial study where the surgeons also knew what was happening and the patients also knew.
And this was a multi-center one, right? Only in Norway.
Only in Norway, within Norway, yes, sir.
Okay. Yeah. So, and how many patients were there in this? 130, you said, no?
Yes, sir.
No, 130, yeah. So this is quite a game changer for the spine surgeons now. If it has been published in NEJM, then it's a problem. They are saying that instrumentation may not be required for degenerative list.
Yes, sir. This paper actually gained a lot of popularity when it was published for the same reason.
Yeah, NEGM has a tendency of doing that. Yeah.
Yeah, Taarini, nice presentation. As Ashish pointed out, could be a multi-centric study, especially the Asian countries, will really help for the Asian populations. This.
Yes, sir.
Because you are included neuro in this, neurological, like post fuse, after fusion. Do you is the neurological point
Yes.
taken?
Yes, sir. They have taken actually both sides, the neurological deficits or complications post surgery as well, and the one that had improvement from the previous. So mostly degenerative spondylolisthesis would not cause any focal neurological deficit except for these symptoms of, maybe radicular pain, paresthesias. So that did improve in a lot of patients post surgery, but the complications which cause neurological deficits were very similar to any fusion surgery, and they were higher in the fusion group.
Any 1 level, 2 level fusion? Any studies showing that?
The Nordstrom trial did not include more than 1 level study, but the others they did. But again, for degenerative listhesis, it's always going to be a single level
Agreed.
listhesis, but canal stenosis may be at 2 levels. So more than 2 was not included.
So then last message from you, fuse or not to fuse, like 2 lines from you.
So I would say that when a patient walks into a OPD and they have a specific complaint that when I walk, I cannot walk for more than 10 minutes. My back pain, my leg pain is more than my back pain. And I am 60 years old. I would tell the patient that I can give you a surgery that is a very less, it is a decompression surgery that should treat your problems. Given that they have degenerative spondylolisthesis, and if I will explain the risk of a slip, but I will also explain that these reoperation surgeries are also 9% infusion, and then it is the patient's decision. But for me, I would always put forward decompression in such stable listhesis patients.
Last question: any red flags you see in the X-ray or the investigation pre-op where you say no, this roughly has to be fused?
No, sir, because X-ray and MRI, when it comes to spine, it is the least reliable thing. The most important is the patient and the patient's symptoms. So I would have to match. But I have seen patients who have severe degenerative changes and stenosis, and they're okay. So it is, wouldn't rely on radiology.
So I got one question for you. We started with Aditya talking about spinopelvic alignment and THR. So how does spinopelvic alignment affect your decision of fusion or not fusion? Does it affect or does it not affect?
So when a patient has
no, did you come across any papers? Because I don't think you mentioned any of those.
The only thing when it comes to spinopelvic alignment in a patient who has just spondylolisthesis, I'm not involving the hip here. It is going to be affected because with stenosis, the patient tends to stoop forward and hence trying to increase the space in the canal. So yes, when I do operate a patient and I see somebody walking with a severe stoop, I would want to operate that and decompress that.
No, not operate. In the sense, your decision on whether to fuse or not to fuse.
Not really, no, sir. The stooping related to spondylolisthesis or canal stenosis, it is not my criteria for fusing or not fusing. That will depend only on the back pain versus leg pain, dominant symptoms, and patient clinical.
Not also the extent of misalignment.
The degenerative listhesis is just going to be grade 1, so it's not going to contribute as much as we think to the misalignment, but the stenosis is more at the culprit here. So when we decompress, it comes back to normal, and like there is a study for that too. So
fair enough.
Out of the box, like if spine patient has referred by arthroplasty surgeon, so what first spine or first arthroplasty?
Again, sir, it depends on the patient. I will have to just ask one question. When you walk, why do you have to stop walking? What makes you stop walking? So when they say that my legs get heavy, I know it is spine. Or when they say my knees or my hips start hurting, then I know it's hip. So it depends on that. And usually joints are more disabling. I would rather do those first and then assess spine, because degenerative spondylolisthesis is never an emergency. It is more like an elective surgery.
Okay. I think we are coming to end of this, and judges can mark Taarini and go ahead. Yeah.
So I think we can close it.
Sure.
Thank you, sir.
Okay. Thanks, Taarini. Sir, you'd like to say closing remarks for this round 2?
Oh, this what? Am I audible or not?
Yeah, you're audible.
Yeah. You want to do?
So I'm in a car just now, and I really thank you very much for making me one of the judges and giving me the importance of being the first person to ask the question. For the last paper, I can say to fuse or not to fuse. Either you are confused or let the knowledge be diffused and dissipated to everyone. From first paper to last paper, it was very engrossing, and I couldn't leave even 1 second not being attentive. All the speakers were so good that I request you that rather than choosing 1, 2, or 3, you can choose all of them, but then you cannot choose all of them. So whatever is my point of marks, you can add with others and see that nobody's done any injustice. And these are wonderful young budding orthopedic surgeons who have really bloomed, not only in budding stage, but they will do wonderful and really draw our nation all over the world, showing the competency and wonderful acumen and knowledge. I thank you very much once again, and marks will come to you immediately on your email as well as on your WhatsApp. Thank you very much, Ashok and Bijlani. You have been really great people doing this wonderful work.
Thank you.
May I other judges also to give their comment?
Thank you, sir.
Thank you, sir. Thank you. Thank you. Yeah, as Dr. Shah said, it's really heartening to see and hear all of you. Excellent presentations. I always felt very strongly about younger generation, and I always feel that this was an excellent experiment, and I proved right all the time, every time. So I thank you once again for participating. Participation is important. Winners are just a matter of sort of completion. Otherwise, all of you are excellent. It's very difficult for me, at least, to mark you. But anyway, we have to do the job. So wish you all the best for your future careers, and hope to see you all in Viro. And Dr. Ashok will inform you about the results. Thank you very much, and good night.
Thank you very much. Any words from Dr. Sachin, Ashish?
Yeah, I like to thanks first the BOS and both Ashok and Neeraj and Dharsar's idea. And really, like I and Ashish were also discussing. So these are all, they can also add up in our journals also, the articles, because really very nice read published papers, and really looking forward, and all the best for the future. And maybe you may come, may not come, but all were good. It is very difficult to choose. Nice initiative. Thank you.
Ashish?
Thanks, Ashok, Neeraj, Dharsab. Thank you very much for this. And most importantly, all the participants, you are all very good. So it's really difficult task. I mean, you have heard each other's presentation all through the last, in the initial rounds to now. Now the competition really gets tough. And I wish, as I said, like, all of you could come on stage on Vyrock and then let the audience themselves decide. But all in all, a very good performance. Very well structured. Everyone speaks very well. You are very clear in your thoughts, and that is very heartening to see. I'm going to recommend a lot of people to watch this particular program, because they can use it as a reference point to use this information in their talks as well. Okay. And yes, feel free to post this on your Instagram, your YouTube handles, and your social media. More and more people should be aware of this. And I have no doubts in my mind that all of you have great careers ahead of you. Thank you.
Thank you very much, Ashish. And like Darsa said, it will be very difficult to choose few from this 7 to go to Viro. Anyway, the result will come to you within 2-3 days, so you can prepare well for Viro. Thanks everyone, and we'll end the program here.
Thank you very much.
Thanks.
Thank you. Good night.
Stop the recording.